Alrighty, good morning, everyone. I hope you are doing well, and we are super stoked to have you here. Thank you for joining us for our fifth annual Advocacy in Medicine Conference. My name is Danielle Laniza, and I am the co-chair of the student-run committee with the same name, Advocacy in Medicine, at the New York Academy of Medicine. Our committee is a group of student health professionals interested in health and medical advocacy. We are thrilled to have you here. If you are comfortable and interested, we would love for you to share your name, pronouns, and program in the chat or your working location in the chat as we get started. We have put together a conference around the theme of community health. We want to go back to our roots of why we became interested in healthcare, and for many of us, working in our communities is a major reason. We come from various backgrounds and identities, and we believe the communities where growth constantly happens. We have a full day of esteemed speakers from keynote speakers to panelists, student research presentations and abstracts, and a workshop regarding student-run clinics. Some logistics for the day. We will have time for Q&A at the end of each section. Please feel free to put your question in the chat or raise your hand to let us know you have a question or comment. And again, this will be at the end of each section. So at the end of our keynote, at the end of our panel, and at the end of the section when we have our student abstracts. And we do have scheduled breaks as well throughout our day. With that, I'm going to turn over the mic to my co-chair, Lori, because we will begin with our first keynote with our keynote speaker. Lori, please feel free to go on ahead.
Hi, good morning, everyone. My name is Lori Zombach. I'm a third-year medical student at SUNY Downstate and the other co-lead for this amazing committee, Advocacy in Medicine, through the New York Academy of Medicine. And it is now my great honor to introduce our keynote speaker for this day's conference, my very first professor and mentor at Downstate, Dr. Arthur Grant. Dr. Grant is a professor of neurology and the director of the epilepsy division at Downstate. His parents were both activists, his mother being twice arrested for civil disobedience, once at the Pentagon and once at a military recruiting center in Vermont as part of the Raging Grannies. He grew up in an environment where freedom of thought and questioning authority were paramount. His primary interests in medical advocacy have been prison medicine and political asylum. He has been a member of Physicians for Human Rights since medical school and has performed over 50 forensic examinations of applicants for political asylum. He hopes that everyone attending this conference finds their own way to successfully combine their medical expertise with their own political beliefs. And now, without further ado, it's my great honor to introduce Dr. Arthur Grant.
Okay, thank you so much, Laurie and Danielle. Can you all hear me? Okay. Well, honestly, I've never been a keynote speaker before for anything. And I feel honored and a little anxious about doing that today. But nonetheless, here we are. So I am going to talk about my experiences as an asylum physician or a physician who's part of the Physicians for Human Rights Asylum Network. And as Laurie alluded to, what that is a group of physicians around the country who volunteer to perform examinations on people applying for political asylum in this country. And I have found this, to me, feels like a way of giving back, of combining my medical knowledge and skills with my politics, and in particular, in this time when a lot of immigrants are marginalized and politicians use immigrants as a scapegoat, it feels even more satisfying and empowering to me to be able to help some immigrants obtain citizenship here in the States. So I know I'm supposed to be inspirational today, but I'm going to start out with just telling you about some of the cases that I've had over the years. And largely, I use the first person here. So just essentially saying to you what some of these clients have said to me. And these stories are troubling, are in some cases horrific, but I'm not telling them to you to to titillate or to shock you. It's just to give you a sense of the sort of person that we help in this political asylum process. And then towards the end, I hope to have the more inspirational component. So the first person who I want to talk about is a woman from Guatemala who I interviewed actually 10 years ago, before the downstate asylum clinic was set up in 2012. And I interviewed her at the Essex County Correctional Facility in Newark, New Jersey. So she was obviously incarcerated at the time of the interview. And this is what she said. And she said, in 2009, I fled Guatemala to escape my husband, Luis, not his real name, a dangerous cocaine trafficker who had abused me for the last 8 years of our marriage. I met Luis when I ran away from home to escape the abuse of my alcoholic father. Unfortunately, I traded one abusive home for another. From the time I was 16 years old until the time I escaped, Luis repeatedly physically, verbally, and sexually abused me. He slapped and punched me on a regular basis. He often hit me with rifles, handguns, and other objects. Over the years, he broke my nose, my tooth, and hit me so hard that I lost consciousness, and repeatedly raped me. He also frequently abused our 3 children, hitting them with his fists and belt. When I finally left him and filed for custody of my children, my mother was murdered the day before the custody hearing. I believe that Luis had her killed to intimidate me and prevent me from pursuing custody. So when I examined this woman, I was able to document all of the scars on her body that were entirely consistent with her explanation of how they occurred in this abuse from her husband. And she ended up obtaining asylum, and last I heard was living in Long Island and doing fine, is working, contributing to society. And although I haven't received an update since after she obtained asylum, so I don't know if she was ever able to get her kids here, but she certainly, obtained asylum and is able to live in this country safely. Okay, the next case I'll tell you about is about a man from Cameroon. And he said, I went back to Cameroon from Equatorial Guinea a week before I was planning to go to the US, and stopped first at the screen printing shop I owned with my best friend. When I arrived, he asked if I could help him fill a large order he had just received for white t-shirts with SCNC printed on the front, and on the back the words, "For Federalism in Cameroon." I happily helped him complete the order. Then I went back to my family's house. A few hours later, I heard my colleague's voice outside the door of our house. When I opened the door, I saw that he had been beaten and was being held by members of the BIR, which is the dominant ruling party in Cameroon, in military uniforms. An officer grabbed and handcuffed me, then pushed me and Abdu into the car. After driving for some time, they stopped at an abandoned house, and the officers ordered us out of the car. One of the officers took a big sip of gasoline from a can and spit it onto us. Another officer lit a match and set us on fire. I fell to the ground and rolled around trying to stifle the flames and then lost consciousness. I woke up in a hospital with deep burns everywhere. I had not been protected by clothes. This guy survived, obviously, but his friend did not. Okay, and here's the last one. This is as spoken to us by a woman from Angola. And what she's saying here is what she's describing is a situation in which she had been arrested essentially on false charges for being politically active with an organization or with a political party that was a minority party at the time. The first question the judge asked me was, are both your parents 100% Angolan? I responded that my mother was from Congo, that my father was Angolan, and that I was born in Angola. The judge said, your mother from Congo is trying to create problems here by creating this political group. Here in Angola, you have to be 100% Angolan to create a political party. This mixing has brought problems for all of us. They continued to accuse me of things and discuss how my mother was from the Congo. After I was put back in the cell, I sat on the floor for about 2 hours. I knew what happened to African women in jail, and I was terrified. I saw 2 soldiers coming and stood up. They entered the jail cell. They said, sit down. I sat down. They said, get up. I got up. Then one of them pulled my legs so that I fell to the ground. Then a third soldier came. They were trying to take my pants off. I tried to fight them off. I really did, but I didn't have the strength to fight 3 men. After I stopped fighting, I just let them do whatever. I was like the meal on the table, and each of them took their piece. 2 of them would stand on my feet to keep my legs apart, while the third one raped me. They took turns. And then when they were finished, they left me there. I have scars on the top of my feet from the soldiers' boots. So I'm going to stop there. And if you let me share my screen, am I able to do that? It looks like I can. So I'm just going to show you, this is the guy who was set on fire, or this is his right arm. You can see the deep scars there all along his upper arm. Here's other scars on him, upper arm. This case I didn't tell you about. Okay, so I'm going to stop sharing. Okay, so that's the gruesome part. But what I wanted to, just hold on one sec here, please. Yeah, so what I wanted to say is, you know, these people are hopeless when they get here. But we can give them hope, you know, by examining them, by providing unbiased, objective data about both their physical scars and their mental scars, you know, PTSD, which almost all of these people have. And as I said, by documenting physical scars, evidence of broken bones, teeth that have been knocked out, burns, and so forth, we can provide a way for people who really are powerless to be empowered, for people who are isolated and lonely to feel like they have people who are advocating for them and who can make a difference for them. And all of those three cases that I told you about, I had a medical student and sometimes also a resident with me, helping me with the cases. And either as interpreters or as scribes or both. And for instance, the woman who was in the Essex County ICE facility, I took a medical student with me from downstate who is bilingual, Spanish, English. And by the end of our time interviewing that woman and documenting her scars, measuring her scars, photographing them, and so forth, the medical student, as before we left, gave her a big, long hug. Both of them were crying. And it was a moment where I knew that we were providing this woman with that, at least a little piece of hope and belief that there were people out there who were trying to help her and were doing it out of the, kindness of our hearts, and because we believed that, she deserved her opportunity to obtain asylum here, just like anybody else who, comes to this country because of experiences they've had in their home country that could potentially qualify them for asylum. So these exams are something that students, medical students and residents can participate in. And I guess the last point I want to make is I love my job as a neurologist and seeing my epilepsy patients, but I know that if I couldn't do that, I have colleagues who could step in and do it for me. But these forensic exams of asylum applicants are something for which there really aren't enough people like us, like you and like me, doing them. They're just, the demand for exams exceeds the supply of physicians who have the time and expertise to do them. So I really feel like doing these exams is a way that I'm contributing my expertise, my medical expertise with my political beliefs to help people who otherwise may not be able to get that help. And it's very satisfying for me. And like Laurie said at the beginning, and I'll end with this, doing these sorts of exams and working with PHR may not be your thing, but there are many ways that physicians and other healthcare practitioners can take advantage of our specialized knowledge and our standing in society to do things that have a political component to them. And I guess I'll stop there and take questions.
Yeah, so my name's Ann Palladino. Am I echoing or is that just me? Okay, all right. Yeah, my name's Ann Palladino. I'm a fourth year medical student from Weill Cornell. First off, I just want to thank Dr. Grant for sharing these really powerful stories and his words of inspiration. It's certainly important work, and so I'm really glad to hear about all of these compassionate healthcare workers and what they're doing. I think we are going to move into the student presentations, but I encourage everyone to put some questions for Dr. Grant in the chat. And then maybe Dr. Grant, you can take some time and answer them in the chat and we can all review them. So moving on to the student presentation. portion of our conference. These are some presentations that students sent in about their work. I was really fortunate enough to read all of them. Unfortunately, we don't have the time to go over them, but I'm very excited for you to all hear about their work. We'll send out all of the abstracts after this, but for now, we're just gonna have a select 5 students share their work. Just as a brief reminder for the students, you have 6 minutes for your presentations. Lori will be keeping time and sending out a 1-minute reminder and sharing your slides, any slides that were sent. And then we'll have 2 to 3 minutes of questions. And with that, I'll leave it to Hannah to introduce our first speaker.
Thanks, Anne. So it's my pleasure to introduce our first student speaker, Ivana Baldi from SUNY Downstate College of Medicine, for the presentation titled Associations Between Enroller Demographics and Subject Enrollment into a Randomized Cancer Prevention Trial. Thanks so much.
Okay, thank you. So yeah, my name is Ivana, first year medical student at Downstate. And just some quick background before I jump into it. Last year, before I matriculated into medical school, I spent my year supervising a research program in Rochester, New York at Strong Hospital. And it's an emergency department research associate program. So it's around 50 undergraduate students that work in the ED, and they enroll patients into various research studies. So literally that means screening all day for patients that are eligible for different studies, approaching those patients in their rooms and asking them to participate in that study that they're eligible for. So one of the studies is a cervical cancer prevention R01. And I'm sure a lot of you already know cervical cancer is a very common cancer in women, but it is preventable if detected early. The problem is a lot of women are not up to date with their screening and are not adherent. So the R01 aims to use text messaging to see if that could increase adherence to the current screening guidelines for cervical cancer. And then to add another layer to that, a lot of women of color specifically are also non-adherent to screening guidelines. So I received a NCI diversity supplement, and it was for that R01. And I was interested in seeing how the demographics of the research enrollers impact the recruitment of diverse populations into this clinical trial. So what I did is I used the REDCap data from, I want to say March 2021 up until April 2022, and did a retrospective analysis to see, okay, does the demographics of the person that approaches the patient, does that impact whether or not they enroll? So I did multiple chi-squared tests of independence. And interestingly enough, and I wasn't expecting this, but there wasn't really a strong correlation between the race of the enrollers and the patients that enrolled. I kind of expected that, people would be more willing to participate if approached by someone that was more similar to them. The only thing that was statistically significant, however, and that's like the bottom graph there, was that white women were less likely to participate if approached by an Asian researcher, which was interesting to me. And that could be due to, the timing of things, peak COVID and misinformation about COVID and how it spreads and stuff like that. But other than that, across races, it really didn't matter who approached the patient. Across the board, Black women were just less likely to enroll in the study, no matter who approached them. And so what can we attribute that to? I really believe it has a lot to do with access. Diversity is very important, yes, but I think a main barrier to participation from diverse populations is access to the research. And by conducting research in a setting like the emergency department, what you're doing is eliminating that barrier, because the diversity is there for you. You don't have to go seek it out. You don't have to reinvent the wheel. So I'm a strong advocate for finding patients or finding participants where they are. And I think the ED is a great place for that. And then secondly, I believe in giving more weight to cultural competency. And I think that we have to go further than just city modules and actually teaching researchers to get to know their populations, understanding what biases exist when selecting who participates in studies. And also specifically in Rochester, we trained the enrollers to know the Rochester population, but also understand what they're facing, what the institutions there have done to basically hurt the trust of the community. And I think by teaching them this way and teaching them to be culturally competent before they approach potential subjects for the research really made a difference. So yes, that's my brief overview. And if anyone has any questions, I'm open to answering.
Thanks, Ivana. Really wonderful research project, and I look forward to definitely hearing more about your work as you continue. I have a question regarding recruitment. So how was it going? Like, so were you stationed in the ED and then you were approaching patients, or your team was, or was this a retrospective?
So it was retrospective. It was a little bit of both, mostly retrospective. Between March 2021 through April 2022, the students were down in the ED screening everyone through Epic and seeing who was eligible for the study, then approaching them. And all this was documented in REDCap. So most of the work was retrospective.
Yeah, I have a question as well. You mentioned something about access in research. I was just wondering if you could elaborate on that a little bit.
Yeah, so I think that when it comes to trying to bring representation into clinical trials, we struggle with finding people without having selection bias. And the ED, I think, is a great setting for that because all types of people use the ED for care for various reasons. And this was done in Rochester specifically, but I'm sure it's the same across the country where, you know, if patients have trouble scheduling appointments with their providers, transportation issues, urgent cares in more suburban areas, all of those problems lead people to go into the ED first. And oftentimes we find that providers will tell their patients, you know, I can't see you for a couple of weeks, maybe you should go to the ED. And so because of that, you have all types of people from different backgrounds going into the ED. So instead of having to go out and advertise the research and, you know, travel and post flyers or whatever, you can just go into the ED and approach them that way. And so our EDRA program, I think, eliminates that access as a barrier because they're right there. Any other questions?
All right. If there are any other questions, feel free to put them in the chat. If that's okay, Ivana, maybe you can just answer it there. Okay, wonderful. Thank you so much for your presentation.
Thank you.
It was absolutely amazing.
Thank you so much.
Yeah, of course. So up next, I'm proud to introduce the research that was done by Karina Sagar that will be presented by their colleagues, Ganesh Modugu, Bianca Ugar, and Dana Masand from Rutgers, New Jersey Medical School. And the name of the presentation is Rutgers University NJMS Human Rights Initiative Asylum Clinic Operations Assessment. Thank you.
Hi, so good morning, everyone. My name is Ganesh Modugu, and I'm a second-year medical student representing the Rutgers NJMS Human Rights Initiative. First off, thank you to all the organizers for putting this together, as well as for the opportunity to present here. I think advocacy in medicine is kind of something that we all strive to practice, and it's a pleasure to kind of talk about how we're working towards that goal. Right, so in terms of our project, I think it's no secret that asylum seekers as a population have been subjected to numerous human rights abuses, and that the process of seeking asylum is not just fraught with legal hurdles, but with significant emotional trauma. I think that makes the entire process significantly burdensome. So at Rutgers NJMS, we kind of identified that kind of community need in terms of easing the asylum seeking process. And essentially, the Human Rights Initiative was started with the intention of building an asylum clinic from the ground up to fill that community need, specifically by providing asylum seekers with the pro bono psychiatric and physical evaluations, along with affidavits that they can use in their legal applications. So we've been doing that since approximately 2020. And at this time, having faced many logistical challenges, as well as growing pains, and especially having navigated the pandemic, we really wanted to kind of reflect on the work that we've done so far and kind of understand how we've been serving the community during this time. So specifically to better understand kind of our community impact, we examined client demographics for all of our cases, as well as the case outcomes. We also really took a look at kind of our general workflow, as well as any challenges that we've had performing evaluations overall, just to get a better understanding of how we can improve the clinic, as well as how we can better serve the community around us. So just for some more specific details, in conducting the evaluation, we analyzed kind of the clinic's general workflow, along with 41 cases that were referred to us between March 2020 and September 2022. The cases were analyzed for information such as client demographics, as well as more operational statistics such as case turnaround time. And all of the case data that we analyzed is stored in our generalized secured case tracker that's maintained by the clinic administrators, such as myself and other members of the e-board for our organization. So before I get into some of the information regarding the case statistics, just to describe our workflow, we generally receive case requests from lawyers who are representing asylum seekers, and then trained clinic administrators who are generally members of our e-board do a preliminary assessment of the case request just to see if we have the capacity to take on the case. Generally, the assessment is pretty basic. It's mostly based off of information such as case deadlines, as well as information such as what kind of application that the client is looking to put forward. If the clinic administrator feels the clinic can reasonably complete the case, then case details are relayed to attending physicians who are a part of our team in order to just get a general sense of availability. And then afterwards, we go through a process of making sure that we have a date and time that works for everyone, while also recruiting medical students and residents to assist with the cases. Any confirmed psychiatric evaluations are conducted generally remotely via Zoom, whereas physical evaluations are conducted in person at a local university clinic. After the evaluation, the evaluating physician, as well as the medical students that were on the case, collaborate to produce an affidavit within the appropriate deadline requested by the lawyer, so that we can provide something for the clients to use in their applications. So within that current framework, generally the current turnaround time for our cases from the point of referral to the time we're able to submit the affidavits to the clients is approximately 47 days. So we definitely are looking to improve that turnaround time. And so looking now more towards like the demographics of the community we serve, the majority of clients that we served were female at approximately 63%, and the average age for all of our clients was 35. The majority of applicants or clients originated from Central America and South America, although we also receive requests from areas such as the Caribbean, Eastern Europe, East Africa, West Africa, as well as Eastern Asia. The majority of our clients are currently located in either New York or New Jersey. And for the majority of our cases, they did require an interpreter with Spanish as the most frequently requested language. So just a quick reflection on the information. We feel that like the statistics are in line with kind of generally who's applying for asylum in the US, and we're glad to be able to help. So in terms of kind of more specifically what kind of cases we receive, 90% of the referred. Sorry, I think I got muted for a second. Yeah. So I think 90% of our referred cases included a request for a psychiatric evaluation, whereas approximately 15% of cases include a request for a physical evaluation. There's just a little bit of overlap there for cases that requested both kinds of evaluations. So out of the 41 cases that we analyzed, and specifically 33 that we accepted, the majority of those cases were for asylum seekers and some other. Sorry. Yeah, some other case types included cancellation or removal, as well as T visa applications. And for asylum seekers, the majority of the reasons for seeking asylum were either political persecution, family or domestic violence, as well as gang violence. Although these kind of were very broad, I think, categories, we tried to group in very specific requests too. So there are also a very more niche kind of requests that we tried to do our best to address. And in terms of outcomes, we heard back from 14 lawyers regarding their cases. And for those 14 cases, 6 were granted asylum, 1 was denied, and 7 were pending. So overall, I think having conducted an evaluation of all of our work, I think it's clear that we've really kind of significantly increased our outreach within the first year. We've over tripled the number of case referrals that we received. And I think this goes back to Dr. Grant's comments about kind of how much demand there really is for this kind of services. And I really think that hopefully we can continue to scale up, how many people we're able to help. And yeah, just with the overall, we really hope to kind of identify further barriers to this kind of stuff and identify any areas where we can help the community better. So yeah, thank you for your time, and I would love to answer any questions if anyone has.
Yeah, thank you so much for this talk, Ganesh. I just had a quick question. You said that your turnaround time was like 40 something days. And you guys were brainstorming ways to shorten that turnaround. So I just wanted to know if you guys had implemented any of those ideas yet, or for other clinics, what advice you would have to shorten their turnaround.
Right. So for us, I think the main barrier always to getting the clinic or getting an evaluation up and running is making sure that we have an attending physician available. So I think right now, our biggest thing that we're doing to try and address that is kind of natively trained physicians at the institution by hosting a training. So we're that's kind of in the works yet. It hasn't really been implemented, but we're hoping that by doing that, we can kind of significantly increase the number of physicians we have available, and that it really won't take as long to kind of coordinate with physicians in terms of when they're able to do an evaluation.
Thanks so much. I also have a question.
Sure.
So this conference started off as a community health themed conference, but between the keynote and actually not just you, but a few of the other speakers as well, in terms of the student presentations, have chosen to focus on asylum medicine, which seems like, sort of a coincidence that we've had this shift. And I'm just wondering if you have any thoughts on why this seems to be such a popular, like, hot button issue for us as advocates and medical students. Like, why are we all so drawn to this topic?
I think it's traditionally just been longstanding, like, something that really hasn't been acknowledged. And I think, like Dr. Grant mentioned, there's just been a growing political kind of emphasis, kind of almost against asylum seekers. So it feels right that, in the conference focus on advocacy, we focus on people who are being, persecuted. And I think that, that's why so many institutions across the US have kind of started to realize that there is a huge population of people who need our help. So.
Yeah, thank you so much for sharing that.
Yeah, absolutely. Yeah, if there aren't any more questions, I'd be happy to, answer them in the chat or personal message.
Okay, great. That sounds amazing. Thank you so much. That was a really wonderful presentation. Really, really interesting. So up next, I'm happy to introduce Anuradha Shetty from SUNY Downstate College of Medicine and School of Public Health for the presentation, Analyzing the Outcomes and Success of a Medical School Student-Run Political Asylum Clinic and its Implications on Public Health. Thank you so much.
Hi, thank you so much for the introduction. My name is Anuradha Shetty. I'm a third-year medical student at SUNY Downstate, and I am the Asylum Clinic Director at our Asylum Clinic. So like was introduced, I'm going to be presenting a abstract created by our Asylum Clinic entitled Analyzing the Outcomes and Success of a Medical School Student-Run Political Asylum Clinic and its Implications on Public Health. So the SUNY Downstate Asylum Clinic is a chapter of the National Organization Physicians for Human Rights, and it was actually the first asylum clinic established in Brooklyn. Our medical students and our residents help our physicians in conducting unbiased and objective medical, psychiatric, or gynecologic evaluations to document medical evidence of past human rights abuses. And the reason these medical affidavits are so crucial is because they're correlated with a higher asylum approval rate when compared to asylees who present their case without these affidavits. The national asylum approval rate is about 46%, and later in the presentation, we'll be talking about the SUNY Downstate asylum approval rate. But the reason this is so important overall is because the applicants that are denied asylum are deported or go underground in the United States, thus at higher risk for poor health outcomes, abuse, and death. The jobs they end up working in are less regulated and are more dangerous. They have the constant stress of being deported, and they're not eligible for any government-assisted medical or food programs. So what we did at the Downstate Clinic is we analyzed these 75 completed affidavits for their content and their outcomes. In order for asylees to attain asylum in the United States, they have to provide at least one of the 5 legal justifications, which include membership into a social group, race or ethnicity, political opinion, nationality, or religion. And while this grouping is one way to classify their reasons for seeking asylum, we were hoping to use a system that allowed us to get a better and more specific understanding. So what we did is we placed the types of traumas that the asylees faced into subcategories under the 5 broad categories of physical violence, sexual violence, other forms of abuse, targeted economic marginalization, and indirect trauma and abuse. The affidavits were then analyzed for their demographics of asylees, such as age and country of origin, and also evaluation characteristics, such as evaluation type and the language the interview was conducted in. The affidavits were also analyzed for legal outcomes. So of the 75 affidavits completed, 35 to date have a legal outcome. And of these, 32 were granted asylum, which means that the SUNY Downstate asylum approval rate is about 91%, which is nearly double that of the national asylum approval rate. And as far as the types of traumas goes, we found that the 2 broad categories of physical violence and other forms of abuse were what the majority of the traumas the asylees faced fell into, with the subcategories of physical assault, threats of violence to death or oneself, and verbal and emotional abuse being the top 3. So as far as the demographics of our asylees goes, our asylees were majority male, and they accounted for a little more than 2/3 of our evaluations. The asylees' age were majority in the 18 through 29 age group, although also in the 30 through 39 age group, with very few being under 18 and not as many being over the age of 40. As far as interview language goes, the majority of our evaluations were conducted in English and Spanish, but a notable amount were also conducted in French. And as far as modality goes, prior to the pandemic, we were conducting a lot of our interviews in person at the SUNY Downstate offices of our evaluators or within our Brooklyn Free Clinic. Although as the pandemic went on, the majority of our evaluations were conducted over telemedicine or virtually, as we were concerned for the safety of our asylees and evaluators. As far as their country of origin goes, the majority of our asylees were from countries such as Brazil and Guatemala and Nigeria, although a notable number were also from Mexico, Chad, and Pakistan. And as far as evaluation type goes, prior to the pandemic, we were also conducting a notable number of physical evaluations. So as the pandemic went on, more requests were in for psychiatric evaluations, which ended up working well for us, given that we were switching to the telehealth modality. And finally, as far as legal justifications goes, membership in a particular social group and political opinion were some of the more prevalent legal justifications. So in conclusion, our asylum approval rate illustrates how forensic evaluations substantially increase the likelihood of being granted asylum, and medical student and resident participation in forensic asylum evaluations can save significant time for evaluators, thereby enabling them to take on more cases, which, similar to, I think, what was being spoken about during the last presentation, our biggest obstacle to providing the evaluations is evaluator availability. So So finally, increasing the number of evaluations promotes public health, and those granted asylum remain in the United States where they can access employment, live without fear, and have better access to healthcare. So I think I'm gonna stop there. And I'll take any questions.
Thank you so much for your presentation. That was really lovely, and your graphic is super amazing. I have a question regarding the language. So is there hired interpreters or translators, or is it staff members who are bilingual or fluent in the language? How is that done?
So it's a combination of both. We have a lot of students at our medical school that are fluent in many different languages. That's actually one of the things we ask them whenever they tell us that they're interested in helping out and when they go through the training. But if we don't have someone who's fluent in the specific language that the asylee is seeking, the majority of the time, the asylee's lawyer will provide an interpreter for us during our evaluations.
Yeah, I'd love to jump in and ask a question. So I obviously Anu was involved in the creation of this research. So, but I would love if you would be able to share with everyone in the audience today. I know we did a lot of work regarding the categorization of types of trauma that people experienced in terms of creating those subcategories, and even had a little bit of internal debate about what some of those categories could be. And I would love if you could share a little bit more about that.
Yeah, so like I said, there were the 5 broad categories of physical violence, sexual violence, other forms of abuse, indirect trauma and abuse, and targeted economic marginalization. Some things that we were debating a little bit while we were going through the affidavits and trying to categorize the types of traumas, we actually got this categorization system from a previous PHR research. And so the subcategories were already kind of in place for us, and we were kind of just fitting in where we felt that our affidavits would best fit in. One specific subcategory that I remember we were debating a little bit on was firearm related. So this fell under the physical violence, and firearm related was one of these subcategories that we were able to place the types of traumas into. And we were unsure if this subcategory meant someone had experienced maybe a threat with the firearm, like the firearm was placed in front of them and there was a threat there, or if this meant specifically that they were injured because of a firearm related incidents. And so there were some other debate amongst other types of subcategories, but this was one of the ones that we, as a group, as we were going through the evaluations, kind of had to decide on. And we ultimately ended up deciding that firearms related would mean whether they were injured because of a firearm or whether the threat of the firearm was there or not. And so that's how we ended up reconciling that specific subcategory.
Just quickly, if we have time, you mentioned the group of economic marginalization. Can you just describe a little bit more about that and like what the clinic did? Because that seems like, I guess, I don't know, like what health interventions or health documentation the clinic was doing for those groups.
Yeah, so these subcategories under targeted economic marginalization they were denied access to basic needs like food, clothing, shelter in their home country. They were denied access to education. There was extortion, so they were forced to pay some bribes, or they were denied access to employment. And all of these things were things that were happening in their country of origin, not necessarily at in the United States, but we are actually working on a continuity of care initiative at the SUNY Downstate Asylum Clinic, where we're hoping to connect a lot of our asylees with things like English language classes, housing assistance, language assistance, and things that can help them moving forward. We are partnered up with our Brooklyn Free Clinic, which actually provides these things for those clients there. And so we're hoping to use the same sort of systems to get our asylees connected to the resources that they need here. If there are no other questions at the moment, I'd be more than happy to answer any questions in the chat.
Great, thank you so much. Okay, so I'll introduce our next speaker now. Keeping up with the theme of these asylum clinics, our next speaker is Mohammed Siddiqui from Rutgers, New Jersey Medical School. for the presentation titled Examining Mental Health Among the Asylum Seeker Population at New Jersey Asylum Clinic.
Hello, everyone. So I have a poster. I don't know if you guys received it, but would it be possible for me to share?
Oh yeah, sorry. I don't think I had gotten that, but yes, I'll stop sharing now. You're more than welcome to pull it up. Sorry about that.
Sorry. Okay, so hopefully you guys can see that. Again, my name is Mohammed Siddiqui, and I'm a medical student at Rutgers, New Jersey Medical School and a clinic coordinator at the school's asylum clinic. The research I'm going to be presenting today is about some of the mental health evaluations that we conduct at the clinic. So this clinic fills a somewhat unique role in our community, as Ganesh touched upon earlier, where we provide pro bono psychological and medical evaluations in support of asylum seekers and their asylum applications. And so even though our evaluations are primarily for legal purposes, the evaluations that our clinic facilitates provides physicians an opportunity to screen for some common mental health concerns among patients who they might not typically be seeing, particularly among the asylum-seeking population. And so this is really important because the APA reports that nearly 1 in 3 asylum seekers have post-traumatic stress disorder. And so our clinic has been routinely screening clients for both depression and post-traumatic stress disorder, since we can use this information to help strengthen claims for asylum and then also refer them for additional help. And so in this study, we looked back at our records from our previous cases just to see what the prevalence of PTSD and depression were in our overall patient population and get a better grasp of what we can be doing to help our patients going forward. So there were 2 scales that we used to screen for post-traumatic stress disorder and major depression. The scale we used for PTSD was the Harvard Trauma Questionnaire, and it's also known as the HTQ-5. And then the scale that we used for major depression was the Hopkins Symptom Checklist, or the HSCL-25. And these are both scales that have been validated in the past for cross-cultural use and have been used in refugee populations and with asylum seekers before. And so in the past year, we've had, in the past 2 years, we've had roughly 42 requests for evaluations. And from those requests, we've been able to coordinate with our physicians and student volunteers about 32 cases where we've been able to provide medical affidavits in support of claims of trauma. And so the majority of those requests were to support claims of psychological trauma, but there were also requests for physical evaluations to document physical trauma, and then some requests for evaluations of both types of trauma. But from among the requests that we received for psychological evaluations, we were able to go back into our records and find a total of 20 results from the Harvard Trauma Questionnaire and 20 results from the Hopkins Symptom Checklist, looking at a total of 24 case records. And so what we found was, on average, the mean score on the HTQ-5 was around 2.48 with a standard deviation of 0.46, and a mean score on the HSCL-25 of 2.38 with a standard deviation of 0.67. And so in practice, what that means is that 50% of our patients were screened positive for PTSD, and 85% of them suffered from major depressive disorder. And so you can see this on the 2 diagrams that we have up top, where those dots represent individual scores. And about half of those on the left were above the threshold for PTSD. And then on the right, you can see that about 85% of our clients screened positive for major depressive disorder. And so we looked at some different demographic variables as well, such as age, gender, country of origin, current residence, and some others, just to see if there were any correlations between those variables and higher scores on either scale. And we didn't seem to find any significant correlations in those variables. We also looked at reasons why people were seeking asylum, and there didn't appear to be any specific reason that significantly increased the score. But when looking at reasons why people sought asylum, those reasons were really multifaceted, as we've touched on in the previous presentation, and they didn't always really fit into a single category. So for instance, some people may have had a partner who was abusive, but also involved in a gang. And so we were debating whether to include that as a case of gang violence or domestic abuse. And so we ended up counting them towards both, and we tried to basically find a count for each of those reasons and look at which ones were most prevalent. And we found that the most commonly cited reason for seeking asylum was domestic violence, which for us included cases of physical, emotional, or sexual abuse from a family member or a significant other. And that accounted for nearly 1/3 of our cases. And then the next most common reason was gang violence and then religious persecution. And so these findings were pretty insightful into not just the reasons why people were showing up at our clinic for an evaluation, but it also gave us some underlying insights into their mental health and what those concerns are that they're facing. Oftentimes, when we're asked to conduct an evaluation, we're told as for background for the case that they might be forgetful or that they have flashbacks or some other symptoms. But until these evaluations, those symptoms are never connected back to an underlying mental health diagnosis. And so these evaluations provide us an opportunity to inform the asylum seeker about these conditions and refer them for help when needed. And so our clinic physicians will typically ask the client about what access they have for healthcare, and when needed, they'll refer them to local clinics in our area so they can get additional support after the evaluation. So we're always trying to see what we can do to help or support our clients a little bit better. And this year, just noting how prevalent the issue of domestic violence was among our patient population, we were planning on integrating a session on gender-based violence and sex trafficking into our clinic training this year, just so our attendings and medical students will be better aware of these issues and can hopefully navigate these topics a little bit better in their evaluations. And with that, I guess I'd like to end and thank our faculty advisor, Dr. Kennedy, for all of her time and support, and to all of our medical students and attendings who have donated their time. And of course, I want to thank you all for listening, and I'm happy to answer any questions.
Hey, thank you so much for sharing that. That was really amazing to listen to. So obviously, we've had quite fair representation of people doing work in asylum clinics in this conference. And so because we've had these two other presentations related to asylum clinics, I'm wondering how you see that this work in terms of the mental health of the asylum seeker population. How can those of us who are also involved in clinics use that to better our practices?
So that's a really good question. I feel like mental health is the area that's been gaining more attention in recent years. I think it's taken a lot more seriously now. And I think just for marginalized patient populations like asylum seekers, it's really important that going forward, we focus on their mental health as well. And so I'm not really sure what the practices are in different asylum clinics, whether they are screening for major depressive disorder. I know that there's probably some screening for PTSD, but getting these diagnoses and sharing with asylum seekers so they can get additional help, I feel like that's pretty important for us to be doing, since we are, one of those clinic resources that, in terms of community health, that they're going to be visiting, they're going to be encountering healthcare professionals here, and they might not be encountering them elsewhere in their day-to-day life. So it's important that we diagnose these mental health concerns when we do see these patients and refer them for help.
Hey, thank you so much for presenting. I just had a quick question. I know you said that you talked to the asylees about their diagnoses if they screen positive and recommend them. I was just wondering, if students or whoever's breaking this news gets any training in how to do it in a culturally sensitive way, and if you've encountered any barriers or different cultural views on mental health when addressing these issues with your patients.
Yeah, so it's typically the attending for the case who is discussing these topics, and I feel for the most part that they are pretty well at doing that job. One concern for me is that we're often working through interpreters, so I feel like that can complicate communicating that news to the client. And so, yeah, it's a little bit tricky because I know that, when our clinic physicians are trying to communicate that information, they always try to do it in the most empathetic way, but whether that gets passed on in translation, it's a little bit uncertain. But we do try to make sure that they know that they have resources to help support them going forward. And if there are any other questions, I can always answer them in the chat.
All right, it sounds like we're ready to move on. Thank you so much for that really fascinating presentation. So up next, we have Mason Blacker from the NYU Grossman School of Medicine, presenting on traumatic brain injury disparities in American Indian and Alaska Native communities.
Great, thank you so much for having me and the introduction. I think this is particularly germane to today, being Indigenous Peoples Day. So I did not do asylum seeking, so sorry about that, guys. But a quick background on me: I'm a MS2 at NYU, obviously, and both my grandmothers were Native American, and unfortunately, they had a pretty high distrust in the medical system. And I don't know if that stems from their personal experiences necessarily, or the fact that Native Americans have the lowest life expectancy in the US. And so it's pretty near and dear to me. And I'm also in the 3-year pathway for neurosurgery. So, TBI kind of is one of my big interests. So it kind of made sense for me to try to undertake this. So quick background: American Indians and Alaskan Natives experience significant disparities in TBI, like I said here, and that's compared to all other racial and ethnic groups. So I wanted to do a quick systematic review to try to kind of figure out exactly why, if I could, and kind of what the big differences were. So slide. Awesome. Yeah, I used the Prisma protocol, so everything was on the up and up. Slide. And so here's the big findings. The biggest thing is that they have the highest TBI-related mortality in the US, and that's with all racial and ethnic groups. And the big thing that separates TBI in this population specifically is the fact that so many of them are related to interpersonal violence, alcohol, and psychiatric difficulties. And that's more than any other group. And I think if you're familiar with kind of the different medical things that transpire in the American Indian community, alcoholism is a huge problem. So it's really wasn't a surprise that was a contributory, but still interesting to find that it went along with assault and the psychiatric difficulties. Additionally, sorry, if you go back one real quick, thank you. So on top of kind of the contributions to the TBI specifically were, I was interested in how the care was, and as you can see, they experienced longer length of stay and increased inpatient costs. And additionally, they were less likely to be offered post-discharge resources, return to baseline status, and find meaningful employment after TBI. So slide. So quick conclusions, like we talked about, there are big disparities that exist. And another thing I was kind of surprised with was the lack of research. I did a couple other just quick searches, and by far, from my experience, the Native American and Alaskan Native research, especially in this topic, was the least prevalent. So kind of begs the need to kind of dig into this a little deeper. So just some future directions: collaborate with tribal nations. Tribes provide a pretty unique population in that I think 1/3 of Native Americans actually live on reservations. So it's definitely unique to a lot of other ethnic groups. Target and evaluate programs specific to the TBI causes. So like I said, a lot of them interpersonal violence, alcoholism, and psychiatric issues. Uncover the reasons for the treatment disparities, specifically, the cost, length of stay, and then employment afterwards, and then allocate appropriate post-TBI resources to these regions. So there are actual federal funded programs for Native American communities, but it still doesn't even come close to, say, like the federal funding for prison health populations. So I think that digging kind of into that and figuring out how we can allocate not just money, but also physicians. I think there's definitely a huge lack of physicians on reservations and close to these reservations to provide these care. So that could be a reason why the hospitalizations takes longer, because they're less likely to release them to where they came from based on follow-on care. And then I think kind of important thing was what I ended with is that even a marginal decrease in this inequality can have huge impact on this traditionally marginalized group of people. So thanks a lot for having me, and happy to take any questions.
Thank you. I actually had a question. So as you kind of were talking about, there is like this huge disparity in research that's been done on the Native American community. So what do you think is the best way to kind of start to bridge that disparity while still kind of centering the needs of that community and doing it in a way that's, going to be more collaborative than exploitative?
Yeah, that's a really great question. And I think the main way to do that is going to be speaking with tribal elders. So, especially like I said, a third of Native Americans live on reservations. And so there's a huge, I don't want to call it a hierarchy, but really that's kind of what it is. If you talk to anyone who's an official tribe member, they can probably tell you who their tribe elders are. And they're kind of the more trusted individuals, especially, they'll go to what they have to say over, physician. So I think engaging in the tribal elders specifically, not only can you, make sure that there's a trust and like a lack of, kind of using them in a way, but also you can disseminate the information and get, more buy-in from the populace if you do that.
Thank you so much for your talk. I just had a quick question. I know you said there's like a paucity of data about this topic. So I don't know if you have the answer, but I was just wondering if you were able to do any regional or like reservation specific analysis to see, for example, like if there's a reservation with lower rates of alcoholism or more resources to support people with alcohol use disorder, if like the TBI rates go down in there, just to like kind of guide interventions that we can do to address this topic.
That's a really good question. I didn't dig too deeply into like alcohol prevention or things specific to that. I know that like there was a tribe in Washington State, for example, that was like very well focused on, but I didn't see any that were kind of broke the tribes out into any specific thing other than the neuropsychiatric. There was a breakdown based on tribes, but not for alcohol abuse. But that's I'm definitely gonna start looking into that now, though. So thank you for the question.
I also had a question. If you may know, this might be out of the scope of the project or just general. I currently work at a rehab facility, Tier Memorial Herman. So I'm just interested in if you kind of know, where do your patients go next when after they've recovered enough to go on to rehab and start working on their skills again, specific for the Alaskan Native American Alaskan Native population?
Yeah, that's a really good question. And I think that is a huge problem, is the fact that like take New York, for example, right? If someone comes to NYU, they have a TBI, we work them up, put them on the protocols, and then when they're ready, they're released to rehab. So specifically like Rusk for NYU. And so that's the same general area. It's really accessible for a lot of people. Not everyone, obviously, unfortunately, but for a lot of people. And that's a huge problem with the reservations don't have like good focused rehab for TBI. And so from my personal experience, I know that there's been kind of referrals to rehabilitation centers in the area, but not specifically on reservations or, and I don't think that there's necessarily a lack of ability to reach these places, but kind of a more of a distrust. And that's just my personal experience. I don't know the actual scientific data on that, but there's definitely a lack of rehab access within the tribal communities. Great. Well, again, thanks so much for having me, everybody.
Okay, everyone, we're going to take a break until about noon. So then after that, we'll come back and we'll start with the workshop.
Just one minor thing, you don't have to leave the link. We're going to keep the link open. Just keep yourself muted and off camera if you'd like to join the break.
I've been waiting.
Na 250 meter, ga rechtdoor.
Hello, everyone. As we are coming on back, please let us know that you are back by putting in the chat your favorite fall drink or snack, just so we know if everyone is back or not. So favorite fall drink or snack in the chat, please. Amazing. Thanks, everyone. And please feel free to keep on going with your favorite snacks or drinks. If you have joined us recently, also feel free to put in your name, pronouns, and program or where you're working so that we can get that info in the chat if you're comfortable as well. We will be getting started in about 3 minutes. I'm going to start sharing my screen with our slides so that we can get started soon.
But yet, when I was yesterday.
Alrighty. So we are going to go ahead and get started with our workshop portion of the conference. Oh, I don't know if my screen, okay, cool. Everyone can see my screen, right? Amazing. So for this, we will be going over, I'm just trying to move my the little boxes. 1 second. I see a lot. Okay. Cool. We are going to be going over an introduction on how to create student-run clinics. We will be discussing what is a student-run clinic and the purpose of doing these. I do have a dog, so apologies, as sometimes she does like to make a small appearance if you hear barking. So with that, we're going to go ahead and get started. And first, just a little mini intro of myself and my fellow presenter for who's going to do this, who's also a committee member. So my name is Danielle, and I'm a third-year PhD student at the University of Houston in counseling health psychology. And I'm currently doing my rotation at Tier Memorial Hermann. I'm in the spinal cord injury department. And my research and clinical area are somewhat related. I am interested in health services, aging and cancer health disparities, adult populations and older adult populations primarily, and LGBTQ plus mental health services. And with that, I'm gonna have Hannah introduce herself as well.
Hi, everyone. My name is Hannah. I'm a second-year medical student at Weill Cornell Medicine, which is in New York City. And some of my interests for my career include some field of primary care, health equity research, and LGBTQ advocacy work. So I've actually been volunteering for one of our free clinics here, which provides free mental health care for LGBTQ people in New York City. And it's been really gratifying, amazing work. And I'm so happy to continue working in that field.
Thank you for that. And also, so I actually don't have my own student-run clinic. So part of that interest was in thinking about, well, if I were to start one at my university, what would that really look like? So we have compiled this information together. We definitely would love for this to be interactive. We do have an activity at the end. And we know that we have a lot of people who have worked or are working in asylum clinics. So definitely feel free to add in that information as well. So these are the aspects of the workshop that we will be talking about. So aspects of student-run clinics, and then logistics for opening. So there is quite a lot that goes into actually having this up and running. So we touch upon that in an introductory manner. Then we think about the proposal, because this is one of the main components of actually getting your clinic to fruition tangibly. So we want to think about why you're doing this and how you're going to have it happen. We have resources that we'll talk a little bit about, and then the activity at the end. So student-run clinics, what exactly are they and why should we have them? Student-run clinics are traditionally free or subsidized outpatient level care centers. These clinics give students the opportunity to connect with community members, provide care to specific or general populations, and increase access to treatments. Typically, students are the lead providers for logistics, operations, and treatment decision-making, and require attending supervision. And this is an important aspect, and something that you want to think about quite often is who is available in case something goes awry or something is, way above what we know. Who's going to be there to supervise, to help, to aid as we work with patients. And what you'll see later on as well in a graphic about who runs student-run clinics. This is across disciplines. So we do have primarily medical student-oriented clinics, but we also have them in psychology, for nursing, for PA. They really are for mostly all health professions. And so that may make a little bit more sense because that particular graphic doesn't actually add up to 100 in case you do some quick math. It just was based off of the survey that came from UPenn Medical School. So what we're really thinking about for student-run clinics is how can us as students be leaders in our community and provide care to the best of our abilities and at the level that we are trained to do. And a lot of that requires the supervision, but it also requires understanding of our schedules and what we're able to provide, and then being able to have trusted people around us so that we can coordinate this. Because as you all are likely familiar with or going to become familiar with, providing care for patients has a lot of responsibility. So definitely keeping that in mind and understanding that we always have humans in front of us. So making sure we're providing the best care when possible, and really at all times. Here are the aspects of student-run clinics. So a primary thing we want to think about is assess needs and capacity. And why would we want to do that? Well, it goes back to the idea of doing community work. What does our community want? What does your community want? And how can we provide those services? If there are a dozen primary care clinics down the block, do we need another primary care clinic? What actually, if we need more specific or specialized clinics, like an LGBTQ health clinic, that might be more useful to the community because that's not what's available. So assess health needs and capacity. Who would benefit from a student-run clinic? And this is going to come from asking a lot of questions, formally and informally. You want to talk with local providers at your institution or elsewhere. So talking with attendings, talking with faculty, with staff members, and asking them how their hours are, what type of patients are they seeing, what type of referrals are they making a lot, because they don't have that type of care available to them in the community right now. Providers from all disciplines, mental health, medical, social work, nursing, occupational, all have opportunities for care. So let's say, going back to the idea that we have a lot of primary care clinics available, which isn't always true, but it's just using as an example. Maybe we do a lot of social work referral out, or we do a lot of mental health referrals. So how can we kind of bridge that gap and have more mental health treatment available for these primary care clinics within a closer setting? Speaking to members of the community directly can also help to inform care needs. So whether we do that formally by being situated in the primary care clinics that are already available and having some type of survey available, either a verbal one or one that's electronic. And we think about, okay, we have these questions, you want to ask them what they need, how was their experience in this primary care clinic, and what else could they benefit from regarding their health. These types of questions, and especially documented, will really help promote your proposal and getting it together when, which we'll talk a little bit more later on when thinking about funding. Because having funding available for clinics can at times make or break the sustainability of the clinic you're working in. Next, we want to think about what type of care would be needed. So we know healthcare is super dynamic, and we have patients and ourselves who have a lot of needs. We have primary care, mental health, geriatrics, and more. And these are all areas where community members need more care. Or by that, the specialization is not necessarily there, and they could use more individuals trained to provide this type of care to the community now. Thinking about geriatrics, for example, they have quite complicated health concerns as we age. So in thinking about how can we provide more specialized care so that we can reduce hospital admissions or hospital overnight stays might be an important component of your proposal. And then if you can get some data regarding that. So there is a lot of data regarding that within the literature if you look at PubMed, but thinking more about your community. What is your ER admissions numbers look like, and how is that related to being within the geriatrics population, so on and so forth. And you can use that type of logic for any of the healthcare disciplines, or rather the healthcare specialties that you're interested in, and just really seeing how you can inform your proposal with both narratives as needed and then data as needed. Create a survey to send out to local providers at community centers, shelters, to get a better idea on what is desired and needed. So in research, we actually have a formal way of saying community participatory based research. And that's when we are directly working with community members to create a research project and then do the research with the community. So taking that idea and making sure we are asking our community members, if we were to open a student-run clinic, what would be the most useful? How can we be of the most relevance to the needs that are going on right now? And that's a super important conversation to have, because instituting in a clinic that's not going to be used, or it does not have high utility, is not going to be fruitful for hours, it's not going to be fruitful for the treatment available, so on and so forth. And then, as we'll kind of see later on as well, a key area for that is going to be language, making sure we have language options for all community members, making sure we have pamphlets that are gender inclusive or sexual orientation inclusive for anyone who are going to come into the clinic. Next, what providers are available to supervise? So as trainees, we only know so much and we don't have licenses. So we do have to make sure that we're keeping this in mind. If we're going to have supervisors, are they available for the whole day the clinic is going to be open? Are they available for only certain hours? Is it possible to have shifts of supervisors available? And are they going to be on-site or off-site for most of the time? Those are important, and just making sure that we have them available to us for when there's some type of bigger issue occurring, when someone has to go outside the clinic and be referred to the hospital, or so on and so forth, for whatever the problem is, so that we have the available and the correct treatment for anyone who comes into the clinic. So start conversations with your training director, professors, preceptors, etc. about a clinic. Getting this on their radar could be really helpful. If you also know it might be better to have more data available before getting it on their radar, you can definitely feel it out per your program. It can depend on who's available, the faculty, funding, so on and so forth, something many of you probably have encountered already. So this is an example of a health assessment. This is really in thinking about what we can do. This comes from the CDC Change Action Guide 2010, and it is linked in our later resources section that will be available to you. When developing your survey, questions will depend on your population and include things like length or number of questions, language, survey versus interviews, and distribution. So one example that I had said earlier was if you're situated in a hospital and maybe you go to the ED admissions area or whatever admissions area, and you have paper copies available and you can hand them out. It's a very brief way, simplified way, does not always work. Other times, if you're doing chart reviews, maybe you know certain individuals are coming in, maybe they have their contact information there, and that's another way that you can get this information out there. Having it available in a virtual and an in-person or a hard copy might be useful. It depends on your population. Next is really thinking about your questions. So this is, and then my little thing is in the way. So this is in thinking about chronic disease management, which we know a lot of people come in for in primary care situations. And these are specifically asking, to what extent does the healthcare facility do the following things? Because we're really assessing needs. You can assess needs, and that comes up very prominently in the community health literature, but you can also assess health needs. So those are two different words, keywords that you want to look at: health needs and then community or needs assessment. This one, for example, implement a referral system to help patients to access community-based resources or services for chronic disease management. Okay, so what is this really telling us? Is there a referral system? So are there people out there, clinicians and providers out there at the community level who provide resources or treatments, care regarding a chronic disease management? As you all know, depending on the chronic disease, requires various specialties. So this question you may want to tailor to the audience that you have available to you, wherever you're actually doing this survey. Next one, provide routine follow-up counseling and education to patients to help address chronic disease and related risk factors. Does this actually happen? How are people managing their chronic disease for this specific example, and what's going on? So these are examples: poor nutrition, physical inactivity, hypertension, high cholesterol, elevated blood sugar, tobacco use and exposure, and so on. So all of these will require unique treatment or intervention options. So how can we provide either counseling on these in our clinic, and then have available information? So whether that be pamphlets, motivational interviewing, so on and so forth, to educate and provide something to our community members for them to really start thinking about, in this example, their chronic disease management. Next, provide screening for chronic disease in adults with risk factors. So when people are presenting to the clinic, how are we going to assess them? So we know, everyone, from your own personal experiences, if you go to your PCP, you probably have to fill out a bunch of surveys about how you're doing, what's going on, and why you've come in. That's something as students leading the clinic, you'll have to have available for your patients. So having those type of documentations ready will be needed. And this for us, we'll have to think about, is this again going to be a paper copy that we provide to patients as they come in? Is it going to be in some type of virtual format that they'll do on a computer or their own device, so on and so forth. So having these screeners available can make the actual assessment and the sessions with patients go smoother if it's available. If not, if we're going to do this face-to-face, which certainly is possible, how can we also streamline that information? Other ones like measuring weight and height and other vitals as needed. How is that going to look? How is it done already? Are patients okay with the way that it's done? And then how are you going to do it in your clinic? Adopt a plan or process to increase patient adherence to chronic disease management and treatment. So this is specific again to chronic diseases, but when you're having these conversations with your patients, what's going to be the next steps for them as they leave the clinic? Are they going to come back in a week, in a month? Do you have that referral system available for them to go see a specialist? So on and so forth. And a lot of this does come back to as well health insurance status. Do they have the coverage to provide to go see a specialist, or is this type of clinic really the only thing available to them? So what's within our means, within ethical means as well, are we going to be able to provide within the student-run clinic? Other ways, institute a systematic approach rather, to the process of diabetes care as an example, and then institute the latest emergency heart disease and stroke treatment guidelines. So going back to all the various different associations that are out there, depending on what you're interested in, what are their guidelines and how is that information going to be available to our patients? These are all questions for you to start thinking about with your student-run clinic. And really, it goes to the logistics and management portion of running any type of clinic. This is also helpful for you too if you're interested in going into later on private practice and so on. These are all key informations for when you have patients, you have a whole system of individuals coming to you for their care. So types of care. Obviously, there are many. These tend to be quite popular for student-run clinics. And part of that goes to the idea is that it's not as readily available or it's very needed within the community. So we have primary care. We can always use more primary care. We know that there's a primary care shortage. So understanding what we can do at that individual level for our patients is one really great theme, or something that our student-run clinics can really encapsulate. Next, we have family care. How can individuals treat the whole family? If we have anyone from across the lifespan coming together, what is that going to look like? LGBTQ plus health. This one is also super important. How are we making sure that we are affirming all identities and that they're getting the care that they need and deserve? Making sure that we have the pamphlets available, that is inclusive and understanding for all different treatments that all individuals coming in may need, and that it's a safe environment for individuals. Next, mental health. Having mental health care, as we know, is also a growing concern. And doing mental health can be long-term and short-term. So for student-run clinics, it's probably going to look a little bit more short-term, but how are we going to provide interventions that are helpful to them, that if they have to not come back for another 3 months, that they have something to reduce their stress, so on or so forth, for them to then come back to the student clinic 3 months later. And then geriatrics. So again, geriatrics, or the older adult population, have complex issues going on at times. So making sure we're addressing anything that we can at that individual level can be a really important student-run clinic. And there are dozens of other options as well. These just tend to be quite popular for student-run clinics. All right, turning it over.
All right, so I'll be continuing by talking a little bit about the logistics regarding the opening of the clinic. So things that you want to think about before you kind of reach that opening day. All right, so the first thing to consider is staffing regarding who's going to be working at the clinic. So something that's important to think about is both having clinical and non-clinical volunteers and having consistency in who is running the clinic. So when considering like who's going to take on the leadership roles, who will be kind of your faculty guide, you want to make sure it's somebody who really has the time and dedication, especially over a long period of time, to really ensure that the clinic's going to be able to provide that consistent quality of care and stay true to the mission. So I know at my medical school, a lot of the clinic leaders will be MD, PhD students because they're going to be here for a really long period of time, and they'll really be able to kind of maintain that leadership role and pass it on as other people go on and graduate. So just something that's really important to think about. And then also considering how often the clinic is going to be running. So usually when clinics are just starting out, they serve like a smaller patient population. They might have less resources. So they might start kind of small, like maybe one night per week, whatever it might be, depending on the needs of the community. But what's important is just being consistent, because these are real patients who are relying on us for care. So you want to make sure that that's something that they can kind of rely on you for. So then for location, you want to consider where you're actually going to run the clinic. So perhaps there's a location on campus, such as an office space, or maybe there's an existing clinic that runs during the day, but maybe in the evening hours they're open and you might be able to kind of use that space in the afternoon. But something that's important to remember is that you always need to ensure cleanliness, safety, and privacy for the patients. So wherever the clinic is, just making sure they have the resources to provide that. And then for referrals, you want to think about how you're actually going to get the message out to patients that your clinic exists so that they can go and benefit from it. So some marketing you can think about is just using social media. I know a lot of patients find out about clinics through like Instagram or Facebook or Twitter. You can put a page maybe on your medical school's website that advertises the clinic. You can also consider reaching out to other clinics in the area that are already established and kind of letting them know about your mission, and then encouraging the doctors to provide referrals if they do have patients who might fit what your clinic's services are. You can also think about like putting up flyers or putting flyers in other offices. There's really so many ways you can get the word out about it, but whatever it is, just make sure that it really reaches the community that you're trying to help. You can go to the next page. All right, so these are some key steps that you want to think about before opening. So the first step would be to get the necessary approvals for your clinic. So this can vary depending on like what kind of space you're opening the clinic in. So it's important to schedule a meeting with your dean or your program chair to really ask them like what do we need, what kind of approvals do we need before we start this clinic. And if you're going to be running the clinic in a hospital space, also making sure that you meet with hospital leadership to get the approvals for that as well. Something you can think about doing is maybe speaking to other student-run clinics, whether they're at your school or schools in the area, just to see what kind of steps they went through if you really don't know where to start. But also reaching out to your school's leadership is a good way to figure that out. Next up, you want to create your policies and procedures for the clinic. So once you kind of develop the leadership for the student board, you can start working on some sort of handbook that's going to like serve as a guide over the years for anyone who wants to become part of the clinic. So that handbook should include the clinic's purpose, mission, goals, vision, the student clinician procedures, expectations, any sort of paperwork that you're going to have for your patients, HIPAA paperwork, guidelines for ethics, emergency procedures. So what you're going to do, you really want to like think thoroughly about what's going to happen if a patient comes in that you might not have the resources to take care of them with, like where you're going to refer them to, any sort of precautions, intake forms, and other policies. And you want to make sure that when you finish writing that handbook or while you're writing it, that you have your faculty advisors or another licensed therapist to look it over to make sure that all the policies are going to be appropriate for your clinic's performance. And something else you want to think about is where you're going to keep the patient information in a database. So the clinic I work for uses Nexus, which is something that's integrated with our medical school. We keep all the schedules on there. We keep all the patient information on there. Whatever it is that you use, just make sure it's really secure, because this is protected information that you're taking in with the patients, as well as getting them integrated with whatever healthcare system you work, whether that's like Epic or something else, just to make sure that they're enrolled properly. All right, so next you want to develop a mechanism to follow outcomes. So this can either be like just using that patient database that you already have, or you can use some types of surveys, or another example is the quality of well-being scale. You can just provide these to the patients as they kind of receive care throughout your clinic, And over time, you want to see what those outcomes are. And this is important not only just to make sure that your clinic is actually benefiting the patients the way you imagine it will, but also if you want to have research come out of this clinic and make publications, that can be really beneficial to have those statistics when you're advocating for your patients' needs, when you're looking for other resources or funding. Having those numbers and hard data is really going to go a long way for that. And then once you have all those things in place, then you're ready to start scheduling your clients and starting treating the patients. All right, you can go to the next slide. So this is just an example of a clinic model. So this is a mental health clinic that's run in Gainesville, Florida. So you can see that there's a lot of different individuals who are involved in this clinic. There's graduate psychology students, licensed psychologists, physician attendings, as well as medical students. So you really want to make sure that you have all the different types of providers that's needed for whatever your clinic model is. So some clinics might have social workers or lawyers, if that is applicable to what their needs are. You might have some specialists. So if you want to provide women's health, you want to have gynecologists there who are going to supervise. As well as I said before, you want preclinical and clinical medical students. So those who have finished maybe their clerkship rotations or done a certain amount of clerkship rotations, they might be able to help out more with the kind of the clinical side of care and taking the patient histories and then reporting that to the attendings. And if you also have preclinical students or pre-med students, maybe they can help more with calling the patients, reminding them for their appointments, doing the intakes with them, serving kind of as the front desk people who will sign the patients in and give them some other information. So the progression, as you can see at the bottom of this chart, you want to start with patient warm handoffs between the different people who are involved in the clinic, just because it can be a little confusing for them when there's so many people involved in their care. You want to make sure that they understand who everybody is and that they're passed off in a consistent manner. Then for this clinic, they do a brief psychosocial assessment as well as behavioral interventions. That's more of the components of the care for the patient. And then they want the team-based supervision and patient consultation between psychology and medicine. So with the integrated care model, you want to make sure that all the patient's needs are taken care of and that the different providers are communicating amongst themselves to make sure that those needs are provided for. All right, so I'll pass it back to Danielle.
Alrighty. So now we want to think about the proposal. So explaining the dream, the fit, and design of your clinic is critical to get it running. These are what you want to quite literally answer when you're getting all your materials together to propose this. So this could be, again, proposing to a staff member, to a fellow attending, well, to a attending, to funders, so on and so forth. You want to explain to them what you're going to do, why you're doing it, who you're training, and where is it going to happen. So for your who, explain to your audience, whoever it is that's in front of you or who is reading your material, why your student group is fit to run a clinic. So what levels are all of you in your program, and how are you going to have the time to run a student-run clinic, and what's the reason behind this? What's your drive, and how are you going to make it work with your very busy schedules? Your why. Provide statistics and narrative points that demonstrate the gap in healthcare. So you have done that health needs assessment. You have gone within the community and asked them what do they need, what would be most useful to them. And you have data points that are helpful, and you have narrative points that can be provided as well to really provide that full picture of what's going on. You have your how, right? How you will operate and run the student clinic, track health outcomes, market and sustain a clinic. What can happen at times if you have your first opening group of really motivated students to run the clinic, and then the year coming up, they're not so motivated, it's not as relevant, so on and so forth, and then the clinic ends up closing. While this certainly can happen, it's part of all healthcare, kind of thinking about how can we sustain this so that there's a streamlined initiative so that all students coming up behind you can be part of this process, and then have the schedule available as well for them to have it implemented in for their availability. Marketing is also important. So as we know, basically 20 years ago, maybe likely a little bit more, flyers would have been super important, that in-person marketing. But for now, we have a lot more virtual marketing. So how are we going to reach our target audiences and make sure they know that we have this clinic available and we would love to see them there? Even if it's going out to our fire departments and having them sharing the information with them. Could be another one, going out to local businesses and sharing the information with them, giving them the flyer so that they can have it available for their customers to come in and see that this is something that's free, subsidized, so on and so forth, and something that they can get their mental health care or whatever health care it is that the clinic is providing. Tracking the health outcomes. So also kind of thinking about, so we know that X amount of patients came in, they got X amount of treatments, and then we saw a decrease in depression, so on and so forth, just when we did a follow-up 3 months later. Having that information can also help for funding quite a lot, but also that sustainability piece and showing that this clinic is making an impact, and maybe we need more funding, we need more availability, we need more staffing. So this is some of the key reasons why this clinic should continue. And then your where, of course. Describe where the clinic will be located and how it's accessible to your community. Think about transportation. If your campus, for example, is located outside of the city and it would take an hour, 30-minute bus ride to get there, how accessible is that for all community members? What if your community doesn't really have access to cars? How are they going to get to you by public transportation? Also think about abilities and disabilities. Can your clients or patients get to you across the sidewalk with wheelchairs or with canes, so on and so forth. So thinking about those aspects as well makes your clinic more accessible and inclusive to whoever is going to be coming in. Here are some more questions for you to brainstorm. Describe your organization's capacity to lead this project. Oh, and these are not original questions. The link for this is in the slides as well. So think about what challenges exist in the community that may indicate a need for a clinic. For example, low graduation rate, high chronic illness, or a high absenteeism. This is specific to those in high school and younger years. Are there specific healthcare needs that have been identified by the community? For example, dental care, vision care, so on and so forth. Describe how your clinic will address the gap in care. Anticipated patient population, anticipated health services, facilities planning, planning team and process, anticipated schedule, data tracking. So a lot of this is becoming quite similar to what we have talked about, and that's because these are really the key information we need to put a very thorough proposal package together. And then describe the need for a student-run clinic or health center. Don't have your audience guessing why this is useful. Tell them quite directly and as elegant as possible or as clear as possible why this student-run clinic should be a thing. Describe your organization, experience with health centers, and your organizational support as well. And this is also where your student leadership is going to come in because you've taken the initiative, you and your group, to really get this going and then sustain it as you move on in your training.
Okay, so I'll be wrapping up the presentation by talking a bit about resources. So as we've been talking about, creating a clinic takes time, dedication, perseverance, and a clear why. So this is some data just on the value for student-run clinics in education. I think this is something or some type of research that could be referenced if you are meeting with the faculty at your school and proposing a new student-run clinic, just to show them that the benefits go beyond for the community. Obviously, that's the main purpose of the clinic, but there's also a lot of benefits for those who are involved with it. So several studies have been documented, including students with student-run clinic experience, that shows that they have more of a patient-centered approach to care, they have more of an interest in working with marginalized populations, and they appreciate more the care that's provided by interprofessional teams. So it's really something that kind of engages them in that setting and potentially might dictate the course of the rest of their career. So the little pie chart just shows the percentage of different students at different levels who are involved with these types of clinics. So 77% of medical students who are clinical are, 35% undergrads, 90% preclinical medical students, and 30% of health-related graduate students. So, I mean, those numbers really show how prevalent it is. The people are involved in these clinics, and that's really amazing and like, I was so happy seeing this data. And then a study that was done found that there's over 152 student-run clinics in the USA. So it just shows how this has become such a staple among medical schools, and it's so important. And I can only imagine the effect that it's had on the communities. All right, you can go to the next one. All right, so just a little bit about funding. This tends to be kind of where student clinics have a little bit of difficulty. It can be really hard to find funding and resources for clinics. And as much as people may want and have the desire and the plan to start the clinic, this is really something that everybody has to go through in order to actually get it started. So I ranked it by internal and external funding sources. So with regards to the internal funding, I think something that's important to start is just to make your clinic a student group, because a lot of student groups can receive funding of various amounts, and that might be kind of a more simple way to get started with that. If you want to then look for more funding from your school, you want to plan some sort of a meeting with the Office of Student Affairs or whoever is in charge of doing funding for student groups and pitch the idea for your clinic. And this is where you really want to have that detailed plan regarding the structure and model of the clinic, because the school wants to make sure that if they're going to give you the funding, that it's really going to be something that's successful and well planned and actually is going to have a benefit for the community. So any data that you collect about like the community needs or about the outcomes of what your student clinic could provide and benefit to the community, you want to have that all set up, and you really want to have that strong purpose and understanding of what those benefits will be. So that's one thing you can do. You can also recruit faculty, mentors, and physicians who are going to advocate for you to the institution's leadership. That might be something that's helpful in really making your case for why your clinic is needed and why the funding is really important to get. You can also consider tapping into your institution's alumni network for donations. So this can be a little complicated, but if you meet with the Office of Alumni Affairs, you can ask them about kind of what the school's protocols are for reaching out about alumni with these types of things. And then maybe think about having some sort of fundraiser where they could provide donations, which they might be very happy and excited about doing. And yeah, then the last point, just about having those fundraising events, you can collect donations from the community. You can collect donations from other medical students or other medical schools. And I think social media is something that can be really helpful for this also, with collecting kind of smaller donations. Then for external funding, I just listed a couple here that I was able to find on the internet. The NIH has a lot of funding for research projects. You can get an HRSA predoctoral grant, which can actually fund the faculty for supervising the program. So as I said, you really want to have a faculty member who is dedicated to the clinic for at least part of their like professional, like the time that they spend. So you want to be able to compensate them for that time, because they're really going to be dedicating so much to the clinic for a longer period of time. And then you can look up the rest of these later when we send out the PowerPoint, but just a couple I found.
Okay, great. So now it's our activity time where we basically get to brainstorm just a little bit for the remaining time. What we'd like for you, and I'm going to send out the link in the chat in just a couple of seconds. We want you to brainstorm your proposal and really hone in on the who, why, how, where questions. And we're going to go back to those in the slides as well. So please write out your responses in the document that I'm going to share with you. And then we would love to hear about them. We can provide very brief feedback on what's going on, or this is a way for you and your peers to kind of connect and give each other ideas on how, why you're thinking about this clinic and how you can make it work. So I'm going to send the link out right now. 1 second, I have to stop sharing screen for a moment as I get this link over to you all. It is a Google Doc link, so you should be able to download it as a Word doc or as a PDF, whichever one. If that does not work, please do let me know. So here it is, and you should be able to download it. So just look for the file download or whatever the other lingo is. And then as that's happening, I'm going to reshare my screen, and we're going to do this for about 5 to 7 minutes. Let's say 6 minutes. So we're going to the brainstorming is going to be done in 6 minutes, and then that'll give us the opportunity to share any responses that you would love to. We would love to hear what you all are thinking, and then wrap up as well with the presentation in general. So about 6 minutes for this brainstorming. And is everyone able to open the link and download it? Cool, awesome. I'm going to reshare my screen now. So as you'll see in the document, this is what's on the document that you just downloaded. So with that, I'm going to reshare this screen. Cool. So now we have about 5 more minutes for you all to brainstorm. And also, if this may be helpful, there is no right or wrong answer, especially in a brainstorming session. This is more thinking about your why would be really helpful to think about now, and then your who, because that's probably top of mind. All that other information is data that you would want to collect formally or informally. Three more minutes. One more minute and then we'll come on back. If you would like to put your info or your answers in the chat, please feel free, and then we can kind of read them out. And we'll use the remaining time to just debrief a bit on this activity and close out the presentation.
Danielle, question, how are you?
I'm good. How are you, Dr. Gore?
Good. Thank you again for inviting me to participate. I just want to make sure, since I'm just now coming on, so we need to put these answers in the chat, or are we going to talk about them later, or how?
So this is for the, I think I'm not muted, right? This is for our just an activity right now. You can feel free just to take a look at them, and then we'll get to our panel in about 15.
Okay, great. Thank you.
All right, great. So now if everyone could come on back for our quick debrief on these questions. I'm going to go ahead and move back over here. Does anyone want to share their responses? Feel free to unmute yourself or put it in the chat of what you were thinking for your who, why, how, or where, or just the experience in general of kind of brainstorming this. If you found it helpful. If you know already there's some tricky spots that you're thinking about, that you're unsure about how you're going to get that info. Feel free to put that in the chat or unmute yourself. And just as you're kind of thinking or mulling it over, I know for me and my personal interests, I have a huge interest in the older adult population and the LGBTQ plus community. So when thinking about a clinic regarding those two populations, I would want to see, okay, where's the need and where's the desire? How would a clinic benefit those two communities in my location? So I'm over in Houston at the moment. So thinking about what's going to be accessible to both of them. So just as a brief thing, Houston is a car heavy location. So thinking about how both community members would be able to get to a clinic is going to be really important via a vehicle. And if they do have to do transportation, how is the clinic going to be located at a bus stop that would be most useful to them? So where they don't have to walk for, so a kind of funny, not funny thing here, walking for 10 minutes in Houston feels like it's 45 minutes, while walking around in New York City for 10 minutes is kind of nothing, depending on where you are. So that's something to definitely think about. And that's something I know as a person for people in Houston, it would be a big factor in getting to our location. So those types of little things will definitely make a difference when thinking about your numbers and who's coming into the clinic. So, and if we don't have any responses, totally cool. We will transition over to our ending. So 30 seconds, give or take, as we wrap up.
Yeah, so I can talk a little bit about an experience that I had. So in terms of thinking about what I would want for a free clinic, I guess my perspective was a little bit skewed just because Downstate already has a free clinic. So I was thinking more about what my experience has been, what my experience there has been like, and how it's shaped, what I think about as being important to a clinic. So I'm going to share a little anecdote of a patient experience that I had at this clinic. So this was my first year at medical school. I was an MS1. And I was volunteering at the Brooklyn Free Clinic, and I had a patient come in, and he was a male patient in about his mid-20s. He came in with his fiance. He was an undocumented immigrant from Ecuador with no health insurance. He had come in for an unrelated complaint. I can't remember exactly what it was, but we offer free HIV screening to all of our patients, and he wound up testing positive. And he had no family in the United States, didn't really know a ton about HIV, but knew enough to be scared about it. And he ended up crying, and I spoke to that patient for maybe an hour and a half, close to 2 hours, speaking to him and his fiance together, to just the fiance, kind of as they rotated in and out of the room, speaking in English, speaking in Spanish, providing a lot of education about HIV. What are the next steps? What does it mean if you test positive? What is the difference between a screening test and, and a diagnosis, things like that. But mostly just trying to provide emotional support to this couple, and specifically to this patient who was just really freaking out. I could tell that he felt really alone in that moment, and that he was really grateful for that opportunity to speak to me at such length. So when I think about this, I think about, the necessity to have, yes, like language accessibility and cultural competence and all of that, but also the fact that I was able to have enough time to spend close to 2 hours talking to this one patient, as opposed to if you're in a clinic where you have only 10 minutes to see a patient. I think having the luxury of time is really important in those moments. Like if you're going to offer an HIV screen, if you're going to offer something that has the possibility of having, such significant results when they come back, it needs to be able to impact the way you're going to react to them. So you can't give someone news like that, hey, you screen positive for HIV, bye, see you next time. Like, I think when we do these things, our resources are stretched so thin, and our resources include time, but I think it's important that you have something built in like that where you're able to spend a significant amount of time with just one patient.
Yeah, thank you for that, Lori, for sharing that. And you bring up a really good point of, as students, we have different availability from full-time clinicians. So we can spend those 2 hours, like you had said, a bit more easily at times than an attending would, so on and so forth. So we definitely have a lot of care that we can provide in a different capacity than other people for student-run clinic specific. So thanks a lot for sharing that. I'm thinking we are gonna go on over and wrap it up. So this is a toolkit. So a lot of these are linked within the PowerPoint. This is how we got our information and created this workshop for you all. So this will be available to you. These are links, and we have readings as well. So just kind of thinking about, everything that is involved in a project like this, how are you going to make it work? So these are some here. This is not the entirety of everything that you'll need, but definitely a way for you to get started with getting your student-run clinic going. We do want to say thank you so much for participating in this workshop. And then if you do have any questions or comments, put it in the chat and we can get to it later on, because I believe we are transitioning to our break, our brief break.
Yep, we're going to go on break for about 5 minutes. So come back around, I guess, 2:01 then. Thanks, Danielle and Hannah, for the great presentation. And thanks, Jesus, for sharing your example in the chat. All right.
Hello, everyone. So if you can drop in the chat, I would say an emoji, but on Zoom, it doesn't always work so well. So just go ahead and drop in that you're here and available, and we're going to start introducing our speakers in about 1 minute, 45 seconds. And speakers, once you are settled, if you feel free to put your cameras on as desired, as we will be introducing you in again about 30 seconds or so.
Yeah, just while everyone drops their emojis in the chat, I just want to introduce a little bit the panel. We'll hear a little bit more about their accomplishments in a bit, but just to tell you a little bit about what's going to happen in the next hour, we have a panel of 4 experts, all involved in community health initiatives. We'll have about an hour to pick their brains about their advocacy work, how they balance it with their clinical work, and any other questions you all have. Sorry, we got some dogs in the apartment. I'm going to start off with a few basic questions just for all the panelists, but I definitely encourage everyone to drop their questions in the chat, chime in verbally, or if you want to just like private message me them, I can ask them for you. So without further ado, Daniela, would you want to begin introducing our panelists?
Definitely. So I have the pleasure of introducing Dr. Beverly J. Gore. She completed a postdoc fellowship at the University of Texas MD Anderson Cancer Center. She is a registered dietitian and has conducted several studies on nutrition and minority populations focused on reducing obesity and cancer risk. Dr. Gore is a co-founder of the Asian American Health Coalition of Greater Houston, Inc., and the Hope Clinic, a federally qualified health center providing primary health care to Asians and other residents of Southwest Houston. I had the pleasure of first meeting Dr. Gore when I was working at MD Anderson on a project, and she graciously was one of my community outreach advisors. And she gave me super helpful information when I was looking to connect with the community members, as I am not a person from Houston, and it was super valuable, and I thoroughly enjoyed being able to work with her. I also have, and Dr. Gore will be able to give you a bio of herself, a little bit more about herself in just a little bit. I also have another speaker that I have the pleasure of introducing as well. Dr. Eileen Flores has a doctorate in public health and an MPH degree with a concentration in health systems organization and policy at Penn State College of Medicine. She earned her bachelor's degree in neuroscience and behavior at Barnard College, Columbia University, and her master's degree in public health with a concentration in epidemiology at New York Medical College. Eileen's primary research interests are addressing health disparities with an interest among minority and aging populations, and utilizing the research to inform policy. Her dissertation work was a mixed method study that studied opportunities to work with Hispanic adults to promote education and prevention of skin cancer in Central PA. And then I had the pleasure of first meeting Eileen during the this previous summer in DC, where we worked on a health and aging policy internship. And I so enjoyed working with Eileen. And once I heard about her dissertation, I was like, oh, I need to hear more about that. And I need her to be on this panel. So that was just super lovely. And I'm so glad both the speakers and the remaining speakers are here with us as well.
Okay, the next speaker I'm so excited to announce is Dr. Raymond Gist. He is an assistant professor of pediatrics and the director for pediatric critical care medicine at SUNY Downstate Medical Center. He obtained his BS in biomedical sciences from the Sophie Davis School for Biomedical Education and his doctorate in medicine from SUNY Stony Brook School of Medicine. He completed his residency training in general pediatrics at Cohen Children's Medical Center and his fellowship training in pediatric critical care medicine at New York Presbyterian Hospital, Weill Cornell Medical Center. Always making it a priority to give back to his local community, Dr. Gist currently serves as the clinical director for the Kings Against Violence Initiative, or KAVI, which is a hospital, school, and community-based violence intervention and prevention program located here in Brooklyn, New York.
Okay, and Then, sorry, let me fix my.
All right, I can introduce our last panelist. It's Dr. Sapker. Dr. David Sapker went to Miami University of Ohio for undergraduate, the Medical College of Ohio for medical school, and then served his internship, residency, and fellowship at the Ohio State University Medical Center. He's a full-time cardiologist in Columbus, Ohio, and he founded Walk with a Doctor, which is a nonprofit organization that offers free physician-led walking groups throughout the year. He still leads his local Walk with the Doctor chapter every Saturday morning. So to kick everything off, I know we just went over, a brief resume of everyone, but can each of the speakers just tell us a little bit more about themselves, their organization, and their role within it? And I think just, if anyone wants to go first, you can volunteer. Otherwise, we can just start alphabetically and start with Dr. Flores.
Sure, I'll go. Thanks, Danielle, for the great introduction. I'm so glad to be here, and it's nice to meet you all. Like Danielle mentioned, I am a recent graduate of the doctorate program at Penn State College of Medicine. I work primarily with the Penn State Cancer Institute in Hershey, Pennsylvania. Most of my work was done with the community. Like Danielle mentioned, I worked a lot with the Hispanic community, looking at improving cancer prevention behaviors. And my work was specifically in skin cancer prevention, but I'm also a great advocate of cancer prevention behaviors in general and reducing health disparities, especially amongst our minority populations. In Pennsylvania, I was really involved with improving behaviors among the rural populations, which was something I was new to, especially being from a metropolitan area. I'm originally from New Jersey, New York City area. So yep, thank you.
That's wonderful. Dr. Jess, do you want to go next?
Sure. So thank you, Lori, for that great introduction. It's such an honor to be here and to have been invited to speak to this amazing audience. So yeah, just a bit about CAVI. So what we do is we look at violence in our communities as more of a public health issue, right? It's not a moral failing of individuals who are inherently criminal, right? I think we all find knowing that this is an outdated way of looking at these issues, but yet unfortunately these tropes and ideas still exist in our society. So, we look at it from a prevention and intervention standpoint. And so, from our prevention piece, like we're in schools in Brooklyn, and we have various community programs for folks who've either experienced violence or who are involved in trying to fight against violence as violence interrupters. We do what we call a trauma-informed approach, which essentially means that throughout all of our programming, we try to make sure that we aren't unintentionally re-injuring patients. We use our field of justice as one of our principles as well, looking to get people back into the community, looking at folks as redeemable and can actually be healed from whatever caused them to be violent, or either when they were actually a victim of violence, right? And then on our intervention piece, when folks come into the hospital at Kings County with gunshots, assaults, and stabbings, we provide folks with wraparound services to support them as they heal from their physical wounds. We address more of their psychosocial needs. We give youth folks follow-up for 1 year. We give them behavioral health and mental health services, connecting with other CBOs in our community that we work with to provide various assistance such as housing, job training, and other services that will help them along their way. Thank you.
Wonderful. And then Dr. Gore.
Good morning, everybody. My name is Beverly Gore. Danielle, thank you for the nice introduction. One of the things that I wanted to say is I'm actually a native Houstonian. And so when she was saying about knowing the neighborhood, I had no excuse. I was born and raised here in Houston. I had kind of an unusual background. I am Chinese American, but I was brought up in a in the Mexican barrios of Houston. And so, as she knows, hablo más español de chino. And so I really am proud of that dual culture, that I appear to be Chinese, and I am, but I can relate to the Asian, the Mexican, the Hispanic community because of a language capability. But my community involvement began when I was working on my dissertation. As a dietitian, I was very curious about why Asian Americans, particularly Chinese Americans, like my dad, were developing heart disease when it was assumed that the Asian diet is a relatively healthy one. And so I went about developing a food frequency questionnaire for that community and administered it, and found that there was some interesting phenomena going on, particularly, as many of you know, the westernized diet tends to promote heart disease. And so this is something that we were seeing in our community. Anyway, at that time when I was finishing my dissertation, I was introduced to several Asian American health national groups, and they asked me to come speak. And really, there was very little representation from the South, Houston. And there was a lot of representation at those meetings from the California and New York and Hawaii, where there are large Asian American Pacific Islander communities. But I got to meet a lot of movers and shakers in those communities, which really helped. Fast forward, as she was saying, I worked for MD Anderson Cancer Center from 2001 to 2014. But before then, me and a group of colleagues started a group called the Asian American Health Coalition of Greater Houston. And it kind of became the hub for developing health promotion programs for our community. And we decided that one of the things that we wanted to do was start a community health center. And so 20 years now down the road, we started something called the Hope Clinic, which stands for Helping Other People Through Encouragement. And it provides culturally and linguistically competent services in over 30 different languages to the Houston community. So I'm very proud of that accomplishment. It definitely wasn't done alone, but it was definitely a wonderful journey to be on, and I had the privilege of being part of. So right now I'm retired. I'm still doing some consulting work in the Asian health arena, but that's pretty much what I'm doing right now.
Okay, that's wonderful. And then last but not least, we have Dr. Sadker. I know you were having some issues with the Zoom link. I apologize about that, but we just started. So we were just having each speaker say a little bit about their organization and their role within it.
Awesome. Thank you. I've been on, and thank you for the introduction, Anne, and thank you for being included with these great panelists. And thank you to those of you that have helped with Walk with a Doc. I recognize some names. David Sadker, cardiologist in Columbus, Ohio. And in 2005, I was really frustrated at my inability to empower, motivate my patients to be active. The sedentary rate, or those not getting 10,000 steps, is much less than 5%, unfortunately. So one day I wanted this patient to have to say no to my face when if I invited them to the park with my family, and I wanted to, because it's that important. And 17 years later, we've had just this beautiful roller coaster ride, and where we're now in 36 countries and over 500 chapters of people, of physicians walking with their community, talking with their community, laughing with their community. And I'm equally proud that we have about 45 Walk with a Future Doc programs. So as med students, you can roll up our sleeves and spend time doing things with patients that hopefully is the whole reason you went into medicine.
That's wonderful. Sorry, I'm like on two different devices and I keep getting an echo. But yeah, I'm so happy to hear all about these initiatives. I think it's really wonderful what everyone's been doing. Again, I encourage all our other participants to put some questions in the Zoom chat or just private message them to me. But just to kick things off, I think one thing that all of us as students would like to know is any recommendations you have for us to get involved in the work, and also specifically how you juggle having like these really great initiatives with also all of your other work as clinicians and family time and just keeping that work-life balance. And again, we can just start with Dr. Flores or whoever wants to go first.
Sure, I'll go first. I guess I'm probably one of the four of us. I'm probably the newest, newly graduated person, but I can speak to my experiences when I was doing community work with our Hispanic community while juggling my workload with school and also with doing my graduate assistantship work with the Cancer Institute. How I balanced everything, I don't think I had a perfect formula, but I found that working, balancing your work with the community, working with the community, you definitely have to set relationships up and create that initial bond with the community. In my particular situation, I was new to Pennsylvania, to the central Pennsylvania, to the catchment area. So I had to really get into the community and, link up with organizations that were familiar with the Hispanic community. So for example, we had a big office of health, cancer health equity. So I reached out to them and I started attending, meetings with the Latino, like related to Latino cancer prevention and any conferences that I could get a hold of, just being an attendee and listening to people speak about the concerns in the community. That was really helpful for me because even as an attendee, I would just meet people and talk to them and make sure that, I got their names because 4 years later, I found myself reaching out to the same people. COVID happened and it became even more important for me to reach out to them or have their contact information via email or cell phone. So I was really grateful for, establishing an address book early on when I started my community work. So I think it's a good idea to, like I said, to just make sure you, if you are concerned with an issue in your community, start to talk to people. You never know who you're going to meet, who might later on be a resource for you in the future. So, I guess, I spent a lot of my community work outside of schoolwork. So it was basically kind of filling in the gaps of time whenever I could call them or do any other calls or emails. I would do that around whenever I had some downtime with my schoolwork / graduate assistant work. Thank you.
Yeah, that's wonderful. I think like a main driving point, hopefully, that everyone gets from this conference is the importance of community-based connections and really engaging with your community and getting out there. Dr. Gist, do you want to give us any tips of starting out or balancing things?
Yeah, absolutely. I wanted to kind of elaborate on a point that Dr. Flora just made about engaging the community. A lot of times as folks in medicine, we think we know everything, we have the best ideas. And so while we have good intentions, sometimes what happens is it ends up being more of like imposing views on a community, right, who's lived that experience for a very long time. And so we have to be mindful to not have a colonial approach to helping folks. So it's really important to really identify an issue that you think is important, and then find out who's already doing the work right on the ground. Because there are people who have thought about this likely before you have. The odds are that people are already thinking about this and working on it. So find out who's doing that work already, right? Get some experience with them, maybe even volunteer with them, know the lay of the land first. And then as you kind of get to know things, then you start to think about, okay, what is my approach? How can I use my expertise as a clinician to bring a different spin to this to help out those who are already doing the work on the ground? I think that's super important. And then as for balancing it out with, your work, I think one of the pitfalls as a student is that you can really get so engrossed in the work that sometimes your studies suffer. And I think it's important to make sure that you are still maintaining your GPA or your studying habits, your health habits as well, because it's super important that you kind of balance that out. I would also say if you can find a way within your academic curriculum to integrate this advocacy interest into your coursework, maybe your school has an advocacy elective or a pathway that kind of aligns with that. So that will definitely help you out in balancing your academics with your advocacy. And I think I'll stop there.
Yeah, that's really great advice. I know that my school does have like create your own electives where you probably could fit in some of your advocacy work. So that's a great thing to keep in mind. Dr. Gore, would you like to go next?
Thank you. I have to just say ditto to Dr. Flores and Dr. Gist about what they said. The only other ideas that I had would be, for me, it has to be a passion too, I think, because, it does take time and you have to be willing to spend the time in the community to do this sort of thing. In fact, it's an interesting comment that was once made to me. I was speaking to a mixed group of people, a health disparities lecture, and an African-American young lady asked me, Beverly, do I have to be Asian in order to go to the Asian community? And I said, no. I said, what you have to do is show that you care. That's the main thing. And I said, I know a lot of Asian Americans who really, you would think they might want to go out into the Asian community and advocate for them, but not necessarily. And if it's not their passion or concern, that comes through. So it has to be a passion. Network is another key word. As Dr. Flores was saying, I go to a lot of meetings. Don't be the dominant one, be the listener and listen to the community's concerns. Some of you may have heard of the term when I was getting involved in this was community-based participatory research, as opposed to the traditional way of research, which is centered more around the researcher. CBPR really centers around the community. As Dr. Gist was saying, listen to what are their priorities and what is their approach to a problem. Like, I think as healthcare professionals, we all think that obesity is a big problem. And, as a dietitian, I really do too. But on the other hand, how does the community see it? Maybe they see it as, oh, that person has food, whereas somebody who's really thin is, that person doesn't have food, and so you have to kind of think from their perspective. And then as for balance, I have to say, I'm very thankful that I had family support. My husband didn't mind me going out and doing things. And I only had one child at the time. And so I can't, I just really have to thank my family for supporting me during that time.
Definitely. And then Dr. Sadker.
So I hate saying I agree with all the other speakers, but I really do. They hit on points I've written on, just my own. So like Eileen and Beverly said, like, I know right now it's in vogue to learn how to say no to things because we're all overwhelmed. Here, I think it's really important to say yes. And just, I don't remember saying no too much over the last 17 years. I think that's important because that person, it always comes back around and you're always glad you did it. Also, self-care, we don't do enough of that, especially med students. So you have to make sure that is addressed probably first. And then I would say second is realizing, as Beverly was saying, who is making this possible? Someone, for everything you say yes, of course you're saying no to something, and maybe I'm saying no to my wife. So I need to keep that in mind, that maybe there needs to be a lot more back scratching going on, and realize pay the people who are paying you with giving you that liberty to pursue your passion. A resource that is fantastic for all this is We Feed People. If you guys are familiar with Jose Andres, he has the World Central Kitchen. It is a beautiful documentary that hits on all this in vivid detail as he goes and feeds places like Ukraine or the Bahamas, places that have been hit by disaster. And then as far as following your passion and juggling, I've been a full-time cardiologist the whole time. I never thought I would be able to do both. And I think it's because it's that old cliche of if you do what you love, you never work a day in your life. So I think as long as you're passionate and you feel that needs to be part of the fabric of life moving forward, then you really will be surprised with what you can do in your capacity. I'll stop there.
Yeah, I definitely think family support, friend support, and self-care are huge components of this. And you're right, I do think medical students are not the best at juggling all of those, but hopefully throughout our career we get better at that. And then I just have one more general question for everyone, and then a few speaker-specific questions. But I think we were all kind of interested in the funding structure of your organization. I don't know how involved you are in that aspect, but if you could just talk about what funding sources your organization has, whether it's grants, whether it's through your hospital or institution or fundraising.
I'm going to go ahead and start, since I actually started a nonprofit before we started our clinic. And actually the clinic still operates under the nonprofit status of the Asian American Health Coalition. So I have to say, there's 4 of us that are considered the co-founders for the Asian American Health Coalition. And one of them was really pretty good about nonprofit development. And after we got our nonprofit status, we started looking for grants. And our first grant actually was with the Aetna Foundation. And they gave us $25,000 to seed money to begin our clinic. Prior to that, we actually went to the Texas State Department of Health Services, and they gave us a planning grant too. So we got some planning money, and then we were able to get actual operational funds. Starting out, like I said, $25,000 doesn't go very far now, but it was at least at the beginning. And the clinic in the beginning was really just a 4-hour a month volunteer operation, and we charged $5 to each of the patients that we saw. So it's very humble beginnings, but now we've grown tremendously. And so we started as a federally qualified health center. Now we do get funding from CMS, the Centers for Medicare and Medicaid. As you might know, FQHCs get enhanced reimbursement for seeing Medicaid and Medicare patients. But we also still get grants from like the Komen Foundation, American Cancer Society. In Texas, we have something called SECRET, which is the Cancer Prevention Research Institute of Texas, which is kind of like our state NCI. So we do get funding from them. Our CEO has been very innovative and looking for funding for various issues in our community. We have mental health funds from the Hogg Foundation, which is a mental health foundation here in Houston.
You hear that? What? The Hogg Foundation?
Oh, did I say something wrong?
This doctor's and she's a PhD in nutrition and related.
If you could please mute yourself. We just hear the feedback.
Okay. No, there is something called the HOGG Foundation. It was a name of a prominent family here in Houston. But a variety of sources, even though we do get, like I say, the CMS funding, Medicare, Medicaid reimbursement, still that only makes a partial amount of our funding for our clinic. We do get third-party reimbursement from insurers as well, and many foundations.
Wow, that's amazing. A lot of different funding sources. Before we move on, could you, I just had a quick question. Do you have someone in charge of managing all the finances, or do you kind of just all like tag team it?
Well, in the beginning, it was, like I say, just a group of volunteers, but now it has full infrastructure. There's a chief financial officer, CEO, COO of the organization, and they manage all of those funds.
Okay, yeah, it seems overwhelming for so a non-expert to manage. Does anyone else want to chime in, any of the other panelists, about their funding structures?
I can go. We also started the nonprofit back in I think it was 2008 when it was finally formed, but I would recommend, again, showing your passion and being assertive, looking for, so we asked for pro bono help, and we did have an attorney just do everything to form our nonprofit, which was great because we didn't have any money. I was pitching media pretty regularly, and that led to actually $1 million. We had a small article in Cooking Light magazine in 2008, and then an insurance company came on because General Motors wanted them to do Walk with a Doc. That led to $100,000 a year for 10 years. We were really lucky with that. That allowed us to get on our feet in a big way. That came through just showing your passion, showing your excitement. And then I recommend another resource called The Cathedral Within. I believe the author's name is Bill Shore. He talks about having almost a for-profit arm. So for Walk with a Doc, now we made it that hospital systems that want to co-brand, we charge an extra fee that helps pay for underserved programs, medical student programs, residency programs. So and then over time, it takes a lot longer than you would think, but we built up great partnerships with the Texas Medical Association, the Haas Avocado Board, and many other fun groups.
Yeah, that's wonderful. I definitely have heard or read a lot on reading about nonprofits about, before you start a nonprofit, consider whether you want to make it a for-profit that, has a mission to do good, because there's just different funding, there's different logistics that go with each. So I think that's a very great technique of merging the two ideas of non and for-profit. Dr. Flores and Gist, do either of you want to chime in about funding structures for your organization?
I don't think I have much to add because the other two have said so much that were super credible in the area. But what I'll say is that for medical students to kind of bring it back to what I can do, the key term here is sweat equity, right? People are going to fund your efforts, not just ideas, right? So you actually have to put some work in ahead of time to bring your idea to fruition and show some results first. And that's when people are going to jump on board. So I think sometimes people think that if I have an idea, I'm going to apply for a grant and I'm going to get it. It doesn't always work that way. So I think it's important to keep that in mind. And one thing I wanted to add too is about being genuine. Your passion should be genuine because people can see when you're just doing something for an ulterior motive, particularly when you're on interviews for residency or for whatever you're going for after you finish school. It shows. So I think that linking with the community first, putting in the work ahead of time, having some results first, incorporating your academics into that work, and then using those results to then go and get your funding will really go a long way as opposed to just a single idea.
Yeah, wonderful. Dr. Flores, I'm not sure if you have any last thoughts.
Yeah, sure. I totally agree with you, Dr. Gist. So when I did my dissertation, I had an idea, and it was a relatively new idea, trying to link up. I was trying to increase behavior. I wanted to see how I can increase behaviors amongst the Hispanic population in a specific area in the community. So when I was looking at funding, because you have to consider how you're going to fund logistics and incentives and things like that for my study. I looked at bigger, like the NIH grants. My mentor at the time, she had a big NIA grant, National Institutes of Aging grant, and we were trying to find a way for my project to fit in with hers, but mine was so unique. So kind of going along the lines with what Dr. just said, I didn't want to just apply for a grant and make my research fit into something just so that I can get the money for the grant. So, I stuck with my project, and I looked at smaller funding organizations, and you really have to keep your eye out and ask people. Again, at Penn State, they had lots of opportunities for graduate students. I so happened my mentor was super resourceful, and she had told me about this one prevention research award to reduce racism, and it was with the College of Human Health and Human Development on another Penn State campus, and they had opened it up to a bunch of to the whole Penn State community. So I jumped on that, and it just so happened that my research fit into, you know, the goals and objectives of this grant. It was a small grant, but I was able to fund a project that I was passionate about, that was very relevant to the community's needs and cancer prevention needs. So yeah, I got lucky with that. So I just thought that, you know, just keeping your eyes out, you know, we always think of the big grants, but looking, you know, just these smaller grants, looking within the community and seeing if other people who you've worked with, maybe they can suggest other organizations that they've worked with that might have some funding opportunities for you.
Yeah, definitely. I think one piece of advice some gave me was like, not only going after the opportunities, but making sure you're ready for any opportunity that comes along, you know, like always putting in that legwork beforehand so that you're ready to jump on these opportunities as they present themselves. So moving into some slightly more specific questions, but Dr. Flores, Gist, and Gore, you all work with kind of more specific populations, so whether that's Hispanic, Asian populations, or adolescent populations. Can you tell us a little bit about specific issues facing these patient populations, and then maybe some like recent innovations or research that you know of that we can implement as healthcare providers in the future to help eradicate barriers to health? Sorry, that was a very long question. Tackle what you can.
I could start with that. I worked with the Hispanic, I was looking to increase prevention behaviors among the Hispanic community. But I believe this was mentioned before, you know, in order to reach out to the community and make your approach culturally relevant, you need to know, you know, what your community is like, what characteristics make them unique. You know, you can't really generalize the whole Hispanic population. So I reached out to our Office of Cancer Health Equity, and they were knowledgeable of all the community leaders in the catchment area. And, you know, they linked me up with the community leaders first. So what I did was I first interviewed community leaders just to get to know, like, what would be the best approach to reach out to your community, how to talk to your community, what are the main barriers, what will make them do things. So I learned, you know, different radio stations that were unique to like the Lancaster area, where people usually frequent. The Hispanic community that I was working with was, you know, there was a lot of migrant workers, farm workers. So a lot of them feared deportation if someone like me, a researcher, would interview them. And a lot of them didn't speak English. So there was a big language barrier. So as a, you know, I don't speak Spanish, but that's not my primary language, but it would have been a barrier for me to interview them. So how I approached that was I reached out to the community leaders first and interviewed them and asked them, you know, how can I implement an intervention if I wanted to, and what would be the best approach? So that's what I did. I reached out to community leaders, spoke to them, and you know, they all spoke English because they worked a lot with the community, the Hispanic community. So they were either English only or bilingual. So that was very helpful for me because the language barrier was a very big thing to consider, especially when you want to advocate for something or, you know, implement an intervention in that community.
Definitely. And then just one more quick question. What were some examples of community leaders that you reached out to? Were they, you know, like church leaders, or yeah, like what were their positions within the community usually?
Sure. So one was a priest. He was the leader of the community, and they just so happened to work a lot with cancer prevention. I worked with someone from Blue Cross Blue Shield, or I interviewed someone from Blue Cross Blue Shield, because they dealt a lot with insurance claims. I worked with the promotoras, which are the patient navigators. So they're kind of the middleman between the patient and the doctor. So they're usually people who need help with the language. I interviewed a dermatologist, someone who works with skin cancer patients. I worked with someone who was part of the agricultural farmer workers program because they work directly with the migrant community. Even so, like I did all my interviews on Zoom, and that was a hard interview to get, even just with someone who works with the migrant farm workers. Like I had to keep everything, of course, confidential, but they were super. That was a pretty difficult interview to get. But I tried to reach out to people who work directly with Hispanic populations in counties that had a high percentage. And then, yeah, I worked with that organization. I worked with someone who had her own Hispanic organization. She owned a restaurant, and she also owned a bodega within the Lehigh Valley area. So she had customers coming in from other counties who would just buy her products because they only trusted Spanish products from from their store. So yeah, I think that that spanned pretty much all the people I reached out to and interviewed.
Wow, that's an amazing network. Definitely like very vast and touching on a lot of different like fields, like priests, insurance, migrant workers. So that's amazing. You were able to build it up. Dr. Gist, do you want to go next about engaging with adolescents, barriers that they have to health, etc.?
Awesome. Sorry about my background. I'm home and there's some work going on outside, unfortunately. So one of the advantages that we had at CAVI is that the folks who started it, I kind of came in the middle portion, but we're all from the community, Central Brooklyn, East Flatbush, Bed-Stuy, Crown Heights, and we work in the community. And so in those positions, we already have a lot of community networks locally, so that really helped build our programming a bit easier, although funding was a big issue up front. So I think the issues that impact our community, I think that there is again this misconception that it's only guns that are the problem. And yes, easy access to guns is a huge problem. But again, we look at this issue as more of a health issue, right? How do we change community norms around conflict? So we do that by trying to address the various social determinants of health, right? So how do we address housing, right? How do we address food insecurity? How do we make school a place where students feel safe? These are students who come to schools and they have metal detectors, they can't have their phones. So how do we make school a more safe environment for students? So for example, one thing we did last year is we did restorative justice training for teachers and for the school police officers, right? And that way, they understand that when they're dealing with a youth that is maybe not at their best that day, that there are other factors that are playing in to what they're experiencing in their classroom or in the hallways. In the hospital, we do training with hospital police as well, and various staff members on restorative justice as well. So I think that these are the ways that we try to make it a more safer environment for our students to exist in. Also, we employ folks in the community as well. We use what's called a credible messenger model, where we use folks to come into CAVI who work for us are either of the community or have a certain lived experience that gives them credibility in that work. We also use peer modeling in our school. So a lot of the folks who do the frontline programming are folks who are much younger than we are, because there'll be more of a relative, relationship between them and the students. And then we look at mentoring as almost like a hierarchy. So like they're mentoring the youth and we're mentoring the peers who work at CAVI. Those are kind of things that we kind of address at CAVI, because there's a misconception that we're an anti-gun group. And while we do not like guns in our community that are coming in illegally, there are things that we're trying to do to address the other issues that play into the violence that takes place other than just access to guns.
Definitely. Dr. Gore, do you want to go next about the Asian communities that you work with?
Thank you. And I really am very, this is what we're hearing is great information. You guys are doing some great stuff. So making notes about the Asian community, I think some of the issues that we face is the lack of health literacy and a different perspective on health. For many Asian Americans, I think they feel like preventive health is, for many of the immigrants particularly, that it's a foreign concept. You don't go to the doctor unless you're sick. And so to go for screening, many of them still feel like, I don't want them to find something, then I don't have resources to take care of it. So that was an issue, particularly before Obamacare and some of these other programs came on the market, because the Asian community has a high rate of uninsurance. And of course, like Eileen was talking about, the language barriers, not only, as you know, Asians speak a variety of languages. So it can't be like just one. So Chinese, Vietnamese, Korean, Cambodian, we have so many languages that we need to address. The other thing that I thought about was when you asked about what are some of the disparities in our community. Under the radar, I think people don't realize that cancer is actually a big issue for the AAPI community. Breast cancer, cervical cancer, as well as colon cancer are some of our high rates of cancer. Heart disease and obesity is an emerging trend in our community. What is I have here? And when you ask about who are the people that I approached when I first started getting out in the community is, Asians, like many communities, value education. And so if you would go out, and I'm a doctoral person, but I'm not a doctor. And so if you went out with somebody who was a physician, or at least a nurse, RN, they had some street cred, and you could say, well, this is a nurse is going to talk to you about this and this. So that would help if we would talk to people who were health professionals who the community trusted. So that was all I wanted to add. Yeah.
Perfect. And then Dr. Sabker, I'm not sure if you work with specific populations, but I know your work is all about engaging the community. So did you have any barriers to that?
You're correct. I don't work directly with as many disadvantaged people as I would like to. Our leaders are, in various chapters. And maybe the only thing I would add is that we do build our program on breaking down barriers and putting, white coats out with our communities and everyone speaking on the same level, that the inspiring communities through communication and movement, that's our mission statement. So I think we just want these conversations to happen. We also kind of behind the scenes, while it's walk with a doc, and we are encouraging others to come join for the physical activity and the social connection and being in nature. And then our fourth pillar is education and talking. We almost see that as a Trojan horse, where we can then talk about social justice and climate change, two of our kind of very important issues within our program.
That's wonderful. I have a few other questions that I got sent, but before I ask them, does anyone have any like verbal questions they want to ask? I don't know if they're too long to chat. Just leave some time. Okay. All right. I had a question for Doctors Gore and Sadker, just about when you knew that this idea you had was a viable nonprofit idea, or when you knew that you wanted to grow it into a nonprofit.
I'm happy to go first. Ours was kind of weird. So there were two things. One is I'm in a same cardiology group I've been in for the last 18, 19 years. And the president of the group, who's not too vocal, an incredible person, but he came up to me and said, in 19 years, is the best idea I've ever heard. So that gave me confidence to do something a little different. And then the second thing was Wendy's Hamburgers came to us and said, you know, we want to make this Wendy's Walk with a Doc. Before we even had our first walk, it was like a soccer team relationship, and we had a bunch of community partners pouring in. And I think if there's something that, an idea that maybe may have its place, I think you'll find out with the others wanting to join on. And I'm a pretty average Joe, so I knew this was my one opportunity, and I better do everything I can, because I probably wouldn't stumble across another good idea like this.
I was going to say, I'm a big believer in divine providence. And so actually, I could tell you there was 4 of us that were the co-founders of the Asian American Health Coalition. One was very well versed in nonprofit development, so that was good. One was working for the United Way, so she, you know, they support nonprofits. And then there was me, but anyway, I think that the 4 of us were starting to hear more and more from the community about. I went to the safety net hospital. They didn't speak my language. They didn't understand my needs. They didn't even say my name right while I was waiting in the waiting room. And so I waited there all day. So more and more, we would hear these issues of inability to access the current healthcare system. And so I think that became our motivation to address some of those issues. Like I said, I speak very little Chinese, but I always tell my friends, I can take my little Chinese face to the table and tell the people, you know, we need help on certain things. And so I think it's very, that's kind of what became my role, is I can speak up for many people who don't speak English well. And I think that's, you know, things were just happening that made us think now's the time, and we need to strike now. And it was, and funding came. And like Dr. David was saying, you found really kindred spirits in the community who were saying, I'm so glad that you're doing this, because I think this is a great idea.
That's wonderful that both your initiatives got so much momentum behind them. This is a question for Dr. Gist. I saw on the website, hold on, that you had been put in charge of streamlining the workflow within CAVI. Can you talk a little bit more about like the streamlining you did, and maybe like common mistakes that you see with organizations, like redundancies within nonprofits, or yeah, just some specific things you did to make CAVI more efficient?
Awesome. Yeah. So I think that one of the things that I did with CAVI was to establish, processes, taking a lot of the skills that we learned in our professional education and bringing them over into, this space, which is like a hybrid of the community and healthcare space, right? CAVI isn't officially a healthcare organization, but we're a CBO that has a healthcare kind of spin based upon the nature of the work that we do. So one of the key things was like quality improvement processes, right? So look, how do you bring QI processes, that plan, do, save, act model, a PSA cycle of QI, how do you bring that into this space so that when we look at different cases that we see in the community and things that didn't go right, how do we actually formalize a process by which we can actually do better in the future? I think a lot of folks in the nonprofit space think that they're doing well because they're doing the work, and that's not always true, right? So we use data to kind of inform how we change our programming. I give the example, over the last few months, we've been finding that people come to the hospital with gunshots, assaults, and stabbings. Many of these folks are over 30, but historically the demographic has been people who are 15 to 26, 25. And so that kind of shifts your programming and it forces you to kind of make some changes to address the needs of the community, right? But I think sometimes in this work, you can put your head in the sand, you say, I'm doing the work, I'm checking the boxes, but then are you actually doing the work? Are you changing based upon the realities of what's happening on the ground? And so making things a bit more formal in the behind the scenes process, while allowing the people who come into your program who are clients or students, they have a similar experience up front, but behind we're more organized and we're more data driven in our approach to making programming more efficient and more relevant to the community that we serve. I hope that helps.
Definitely. I love like hearing about quality improvement and data tracking in nonprofits because it's such a big part of the work, getting funding, everything. So yeah, actually, if anyone else has other comments about QI or how you track your impact. I can speak up on, I'm not really good at research and the thought of like measuring hemoglobin A1Cs or weights or blood pressures, I felt might be a deterrent to our visitors to the walk. And we've been blessed to work with the CDC and their scientists have told us, look, we have the data behind the importance of physical activity or the importance of social connection or being in nature. Those studies have been done. So I feel we started all this to get people moving. That's what I want to do. And I was very relieved to hear them say, and they've said it over and over, just get the numbers out there. If what you're doing has been proven, then just grow the number of chapters, grow the number of participants. That's what we want to see metric wise. So I'm more of a ready, shoot, aim. If we're in dire need of something, I hate to put unnecessary research if it's already been done. Yeah, definitely. I think figuring out what metrics you can use, what's like reasonable to use, what makes sense for your organization to be tracking is something that every organization kind of has to determine within their own structure. Let's see. We only have like 2 more minutes left. Does anyone have any last questions or any last thoughts from the panelists before we move on to closing remarks?
I did have a question. Thank you so much to all our panelists for speaking. I am wondering on the research end, so for Dr. Flores and Dr. Gore, how have you used your data you've likely submitted formally to publications and journals? Have you stuck it there and kind of kept it there? And if not, have you gotten it to the public or to community? How have you translated your data for the community?
Sure, I could speak to. So I recently, so I completed my project in I think it was March, and I am waiting to get it published. It's being submitted, but I did not want it to stop there. I felt like it was so meaningful for the community to know how to increase behaviors. So while it's nice to publish, it's nicer to get it out, the information out there, because no one's, when the people I interviewed would ask, oh, like, I'm excited to hear what you found from your research. You know, for me to give them a link to a paper, I'm not sure if they would actually, be able, look at the link. Nowadays, they charge you a fee to look at journal articles sometimes. So what I did was I went back to prior to being in the doctorate program, I was working at Memorial Sloan Kettering Cancer Center. So I worked with a lot of dermatologists and in the dermatology service in New York. And I reached out to my my former colleagues and asked them, hey, do you know any doctors specifically who can speak Spanish to and teach cancer prevention within the community? So one of my former colleagues, he actually introduced me to a doctor who works at, I think it was Massachusetts General Hospital. And he was one of the few cancer prevention doctors who spoke Spanish and actually teaches skin cancer prevention and has actually a lecture already ready to give out to the community about skin cancer prevention. So I reached out to him, and then I had asked him if he'd want to do a presentation for the community leaders. And again, this was all during COVID, so everything was on Zoom, but luckily he agreed to do it for free and spoke. And I gave him the results of my study, and I said, hey, this is what we can give to the community. This is what the community needs. So I had him talk about my presentation to the community leaders and, tell them in Spanish, this is what this doctoral student found in her research, and this is what needs to be done. So I felt like, even though it was a small step, it was something that I could give out to the community in a way that was accessible for me, or easy for me to disseminate the findings. But of course, I'll definitely share with them my research results once, hopefully that gets published soon. So.
I agree totally with what Dr. Flores says. I have to give a lot of credit to my mentor, a gentleman named Dr. Lovell Jones, who said the motto for our Center for Research on Minority Health was science that benefits the community. So he always told me, Beverly, we give the data to the community first. We tell them what we found out. You can work on your papers, but you don't wait to give it to the community. So after I did one of my first major studies in the Asian community, we had couple of press conferences with the Asian community, with the Asian media there to tell them what we found out. So that was really exciting for them to know what we found out. One of my last studies I did was with the Asian Indian community, and that organization that I worked with, the Indian American Cancer Network, it's just a small local group, but they coordinated a press conference that we could do in their community to again announce the results to the community, to give them some take-home messages. So what do we need to do, like Dr. Flores was saying, and it gave them some real relevant things. And I see too, I've gone to professional conferences, APHA, and different cancer meetings, and shared my findings at those things as well.
That's wonderful to hear. Thank you all so much for taking this time to talk with us. I think you all had so much great advice and have done so many inspiring things. So we thank you for your time. If there's nothing further, Lori, would you like to start with the closing remarks?
Yeah, absolutely. Thank you so much for everyone. And thank you, Anne, for moderating that panel. Thank you guys so much for being able to join us today. I'd like to give a special thank you to all of our incredible speakers for sharing their words of wisdom, to our student researchers for sharing their exciting work, to the team at the New York Academy of Medicine, specifically to Laura for their unyielding support, and of course, to the student team at Advocacy in Medicine, whose hard work has made this event happen today. Your unrelenting optimism and dedication to advocacy work has made me so excited for what this generation of future clinicians has to offer the world. To the audience members here, please stay tuned for more student research to be disseminated in the next few weeks. Because we had such a tremendous turnout and input of abstract submissions this year, what you saw today was just the tip of the iceberg in terms of the research that has been submitted to the Advocacy in Medicine conference, and I'm so excited for you to see the rest. So please expect an email with that information shortly. If you are looking to get more involved in advocacy in medicine, you can email us at aim@niam.org, or you can email either Danielle or I individually, and we'll provide those email addresses in the chat for you. We would also love to invite you to our first workshop in our 3-part series, which is coming up on Monday, October 24th at noon, and I'll put a registration link in the chat for that as well. Thank you all again so much for sharing your time and your energy with us today, and I hope you have a great rest of your day.